classification about know about our own classification. In the last 10 years, the last survey, they showed that obesity in women has increased from 16 to 15%. And it is predicted by 2040, it will be somewhere 30 to 40%. And the adult women have doubled in last 10 years. And highest prevalence is in Punjab, J&K during pregnancy, when the BMI is done in first visit less than 20 weeks. And in postpartum, even South Kerala, they were found to be having higher, incidence. Generally, the prevalence of obesity in pregnancy is between 12 to 13%. The obesity is so common that its effect on pregnancy is overlooked. It's not thought of as a high-risk condition, though obesity can be a barrier to reproduction because it is associated with anovulation, and it has long and short-term consequences both for the mother as well as the baby. Globally, if you see, the obesity has contributed to 0.6 million increase in death and 1.8% increase in disability-adjusted life year in the last 10 years survey. So what are the maternal risks? These women are more prone to GTM. The risk is 17% compared to 3 to 4%. Preeclampsia 14 to 25%. There's 12-fold increased risk of venous thromboembolism. OSC, obstetric sleep apnea, can be there in very obese, which can lead to stroke, arrhythmias, breathing problem. Of course, they also have psychosocial issues. Prolonged pregnancy, dysfunctional labor, and leading to higher induction rate, and that also leading to failure of induction is higher cesarean, higher anesthesia complication, macrosemia, leading to birth injuries, more PPH, more infections, more wound adhesions and infection, lactation. All these problems are there in the patients who are obese. For the fetus, there is miscarriage, preterm birth because of medical problem, macrosemia because of increase in weight. Congenital anomalies somehow have been found to be higher in obese women. Cause is exactly not known. Neural tube defects and heart defects are more in obese women. More stillbirth because of all the problems, neonatal death, obesity in the offspring, diabetes in the offspring in later life. So all these problems are there. So a woman who is planning to conceive and she's obese, she should be counseled about all these risks, and she should be advised that she should lose weight pre-pregnancy. This is the best way to decrease problem, and losing only 5 to 10% of the body weight can improve health, and you can have a safer pregnancy. And how you can do it? By lifestyle modification, which includes diet and regular exercise, which are the cornerstone of every weight losing program. And anti-obesity drugs should not be taken immediately when you're planning pregnancy. Either you take the drugs and take contraception because their effect on the offspring is not known, whether they will cause any congenital malformation or not. And bariatric surgery should be done if there is type 2, that is BMI more than 35 with medical problems, or BMI more than 40. But if bariatric surgery is done for weight reduction, one has to avoid pregnancy for 18 months, and contraception has to be used, and oral contraceptive should not be used as a contraception because there would be absorption problem, and they would require nutritional supplement to avoid deficiencies of folate, iron, calcium, vitamin B12 before they can become pregnant. And during pregnancy also, the nutritional supplementation has to be very strictly taken care of. And this slide I put as an afterthought, that when you get a patient who is really obese, more than 35, then you should see whether you have the capability to deliver her. You have a labor table. Once we had a patient, we had to join 2 tables to put her. So if you are in a private sector and you don't have this kind of thing, kindly do not take it as a referral thing, that this is a patient who needs to be referred to a place who have bigger labor tables, bigger OD tables, and BP cuff. If you are handling a patient who is obese, you should have a BP machine with a large BP cuff, compression stockings of large size, pneumatic compression with cuffs of large size, large wheelchair, large trolleys, because we really faced a problem. We realized that we were not really equipped for handling a very obese patient. So what antenatal care is required? We should weigh all mothers and calculate BMI to identify them as what class of obesity they before. And you have to counsel and advise them about the risk so that they try to lose weight. And then you have to discuss with them how much weight gain they have to do during pregnancy. They have to be referred to dietitians for advice. They have to be advised about activity. General advice you can give that don't take juices, sodas, and juice drink. Don't take refined flours. Increase your intakes of fruit and vegetables. Dietary fibers increase. Replace fast food. Carry healthy snacks in your handbags and keep a food diary and review with care provider. Walk instead of drive. Take stairs. Get off the bus. Stop and walk. Walk with somebody. If you have children, take them to park. But basically, they need at least 30 minutes of brisk walk each day. You may not be able to do it initially. She can start with 10 minutes, slowly build it up to 30 minutes. Swimming is a good exercise for those who can do it. And since we already said they have higher incidence of anomalies, so they have to have a detailed anomaly scan and serum screening as with all the patient, but you have to explain to them the limitation of ultrasound because of the obesity, especially the 11 to 13 week scan can be done by a TBS in the abdominal. And for anatomical assessment also, it should be done little later. Now we have the law, we can easily do it, at 22 weeks for these, and they have to be screened for GDM as all patients and 3 times. And patients who've had bariatric surgeries, they should not be screened with the tests we do, the OGTT, because they can have, because of high dose of glucose, symptoms such as diarrhea, nausea, vomiting, and consciousness. So they should not be given this OGTT. They should be doing home glucose monitoring for at least 1 week for the purpose of screening. You have to screen for hypertension and preeclampsia because the risk is higher. We do it for all, but you must have an appropriate size of the cuff, and you must mention the size of the cuff you have used, because if you use a smaller cuff, you'll get wrong readings. Aspirin not for all women, but this is one of the moderate risk factors. So if you have 2 factors, age more than 40, family history, multiple pregnancy, then aspirin 150 milligram would be helpful. Folic acid would be required in a higher dose. And like I said earlier, they may require TVS for 11 to 13 week scan. And for growth monitoring, you may not be able to do symphysiofundal height. It will not be correct. And even palpation may not help you. So you may have to do serial ultrasound, especially in the 3rd trimester. You will have to only probably monitor by ultrasound, and also monitor in the 3rd trimester very frequently for weight gain, depression, anxiety, and obstructive sleep apnea. Because these patients are prone to have, psychological disturbance because of their weight. So weight gain is very important, the monitoring. So every visit you have to wait. And since you are recommending exercise and diet, so it may be possible she may not gain adequate weight as recommended. But if the ultrasound shows that the baby's growth is okay, then can continue with the diet and exercise program. But if there is a decrease in the baby's growth, then the program has to be changed. There are various studies which say a different amount of weight gains, but I think the one given by Institute of Medicine is quite useful, that they say that every week only 0.5 pounds should be gained, and recommended gain is 11 to 20 pounds depending upon the initial weight of the woman, for obese of all cases who are more than 30 kilogram per meter square. The obesity is a risk factor, especially more than 30 BMI is a risk factor for thromboembolism. So you have to calculate whether the patients need thromboprophylaxis, especially after delivery. If she has a cesarean or an emergency cesarean, she becomes a candidate, and she must be given at least pneumatic compression after cesarean. Anesthesia, very important for all patient near term, you should take anesthesia opinion, because there is difficulty in venous access, there is difficulty in giving epidural, there is difficulty in general anesthesia because of the fat present and the glottis falling back. So the anesthetist should see the patient, because we don't know which patient will require anesthesia, which will require epidural. So they should always be counseled in a patient who has BMI more than 30 near term, and so that they are equipped with the problem and which they anticipate, and they can make preparation. And one should avoid general anesthesia, but if required, then of course tracheal imputation, intubation and controlled ventilation, and regional anesthesia is preferred, though that is also a little difficult to give. Fetal heart monitoring may be difficult, we may not be able to, so you should be equipped with a Dopton or a CTG to hear the fetal heart, and you should anticipate prolonged labor. Labor dystocia is there in obese because of pacing. There may be a soft tissue obstruction, and they also have slower labor. It may be because of passenger that the baby is big. It may be because of power, that is very common. They have myometrial dysfunction. So you should anticipate. And if you see the labor curves, you can see as the weight is increasing from blue to maroon, the labor is becoming slower. So be patient. Follow the new WHO guidelines, and don't be in a hurry to call it failure of progressive labor or failure of induction, because you have to be patient with these women. In spite of that, they have higher rates of failure of induction. Therefore, when you are priming, maybe you can use a multi-day, 2-3 day priming, or multi-agent priming, first by Foley's, then by Servigel or Propres. And they would also require higher dose and longer duration of oxygen. So it's preferable to give it by pump, because otherwise you would be giving a lot of fluid. But these are the problems you can have during labor. They have higher chance of PPS, so active management of third stage. And if you are doing cesarean, they should receive prophylactic antibiotic in spite of whatever policy you have for antibiotic. Postpartum, they have, dysfunction in breastfeeding. So you should initiate breastfeeding early, continue for at least 1 year. That will help them to lose weight. They should be mobilized early, should be given thromboprophylaxis if required, especially after cesarean. At least rheumatic compression stockings must be given. They should continue with their weight loss program. If they lose about 4.5 kg weight between 2 pregnancies, it will decrease the risk of GDM by 40%. And at least 10% weight loss over 6 months is ideal, which is safe, and I think it is possible to sustain also. So the care doesn't end with delivery. Then there's a little difference in the contraception because of their increased risk of thromboembolism. Combined OCs are category 2 up to 34 BMI, and category 3 for more than 35. And if there are other risk factors, then combined OCs become 3. Otherwise, as a category 2, you can give it if required. Progesterone only pills are again category 1. Other risk factors, they become 2. And if patient has had bariatric surgery, then these oral drugs become a little difficult to absorb, and they can have failures if forgotten. Otherwise, if not forgotten, they are quite okay. Injectables are category 1 unless you have other problems, but we must remember that when we are giving injectable, either we have a longer syringe or we give a subcutaneous DMP, because otherwise the injection will just remain in the fat. IUCDs are best, category 1 for all things. LNG is also category 1 unless there is other complication present. So you must also remember, like I said earlier, if patient has had bariatric surgery, the effectiveness of OCPs and oral POPs decreases. So they should not be used when you are planning that she should not conceive for 18 months. You should use some other contraception. Emergency contraception, I thought to complete the list, though not a part of pregnancy. It is copper D is the most effective method that woman should know if she has a BMI of more than 26. It may reduce the effectiveness of oral emergency contraception. Uliplestrol acetate double dose may be suitable for women with BMI 26 kg or more. So generally, overweight and obesity are increasing, and they are increasing the risk during pregnancy and birth to both mother and child. Therefore, you have to assess their health status early. You have to give them diet counseling. You have to monitor the risk of medical problem as they can have, and there so that their likelihood of safe pregnancy and a healthy birth is increased. Thank you.
Thank you, Ajla ma'am. It was a very learning experience. Shikha madam, I invite Dr. Shikha Singh ma'am for the concluding remarks.
Thank you, Ruchika. I would like to congratulate Dr. Achla for such an informative and very concise and crisp remarks about a very commonly encountered but very well detailed by her, but not very much discussed elsewhere. Every gynecologist and has dilemmas that what other investigations may be required if she is having a high risk factors, just only obesity. And in each and every detail in the antenatal period, in the postpartum period, all the points were very well enumerated. And also the aspirin, as it is always a high risk factor. So 2 high risk factors, aspirin use can be given, which is very well highlighted by Dr. Achla. It was a very nice talk, and it has also given good messages, and that too very crisp and short. I again thank her for giving such an informative talk.
Krishna madam, would you like to add something?
Just would like to appreciate Dr. Ajla for her wonderful and precise and, like Dr. Shikha said, to the point conveying of all the key messages that have to be conveyed. Personally, when we look at these obese patients, I think most important mistake juniors tend to do is about the DVT prophylaxis. It is again we have to be more careful about this, the anesthesia and the exercise. These are the things which we come most commonly in the during the labor period where these patients, and of course the antenatal and fetal and difficulties and the postpartum period were very well identified by Dr. Achla. Thank you so much, Dr. Achla.
And especially the labor graphs, that labor is slow in obese women. This will never forget.
That should not be an indication, just although the big baby, naturally they tend to have bigger babies most commonly, and that should not be an indication for C-section, because cesarean section itself is loaded with complications in obese pregnant women. So I think, like she has rightly pointed out, you can have a topic on labor in obese, that how to monitor it and how to go about it, and how the newer graphs, the newer WHO graphs would be should be taken into consideration. Yeah, thank you.
Thank you, Krishna ma'am. Thank you, Shikha ma'am. For the next talk, I would like to, next talk is carcinoma in pregnancy. I would like to call upon chairperson, Dr. Archana Trivedi ma'am. She's Senior Consultant Gynec and Obstetrics Department, Sterling Hospital. She's President, Vadodara Obstetric Gynec Society, President, BMS 2019-20, Vice President, BOGS 2019-2020, Secretary, WDWIMA for 2021, practicing since 20 years in Vadodara. Key interest, she's interested in high-risk pregnancy, laparoscopy and vaginal surgeries and DVH. She's faculty for adolescent counseling and menstrual hygiene awareness and anemia eradication programs in schools of Vadodara and periphery. Faculty at various national and international conferences. She is winner of Jagdishwari Mishra Award at ISOPAP and Gujarat Gynec Excellence Award at Yuva Foxy 2020 Ahmedabad. Appreciation Award for Midlife Charity Work at IMSCON 2020. She is winner of Best Paper Award at SAFMA Conference 2016. Attached with NGO Sneh Foundation and Swadesh. She won first prize in West Yuva Foxy Superstar Foxy 2020, Foxy Champion Award 2021, Box Society Appreciation Award 2021, West Zone Coordinator for Breast, Adolescent and Safe Motherhood Foxy Committee. I welcome Dr. Archana ma'am.
Thank you, dear Gurpreet, for the kind words, and I congratulate Ruchika ma'am and dear friend Komal for giving me this opportunity and heading with such a important topics, which I just heard from Dr. Achla. As obesity is as important and increasing trend, so is the carcinoma. I think people are becoming more aware, and that is why we have more and more detections when we talk about carcinoma. So I think you want to introduce the second chairperson before I introduce ma'am. Gurpreet, go ahead,
Yes,
please.
ma'am. I would like to invite Dr. Mala Srivastava ma'am. She is Senior Consultant and Professor GRI PMER, Gynec Endoscopy and Robotic Surgeon in Sir Gangaram Hospital, New Delhi. She is Vice President-elect ISOPAB 2023 and 24. She is past President AOGD 22 and 2020-21. Her qualification is MBBS, DGO, DNB, FIC, MCH, FICOG. Her area of interest is gynec oncology, gynec endoscopic surgery, gynec robotic surgery, fellow of minimal accessory surgeries, trained in robotic surgery at France. She has won many awards and awardee of Women Medical Professional Award by Ayushman Bharat, ICOG Governing Council member 21-22, Zonal Chairperson of ISOPAB, Executive Member of AOGD 2019-2020. He is Executive Member.
She is so much active. So over to Mala madam. Kindly invite our chairperson, speaker of the day.
Ruchika, I'll do the honors.
Okay,
I
ma'am.
think it's my honor. I would say I'm very humbled to introduce my dear friend and a very dear guide, Dr. Leela Vyas madam, who was very adorable, I think, all over India, pan-India. And she has been past Vice President Foxy and has been a key person when I talk about not only Vyas Hospital, Jaipur, but she has been a key person in ISAR, IVF treatment, now aesthetics and cosmetics. So I think madam is fully, I mean, a complete package when you talk about a holistic and a academic gynecologist if we have in mind. So who else can enlighten us other than ma'am when we talk about carcinoma and pregnancy? As myself and Gurpreet were discussing, that it is on rise because of more awareness and more patients reporting in the OPD. And we are also becoming more prone and not losing the art of still doing the PSPV. So I think there is a scope of detection and there is a scope of treatment also. And I would invite Dr. Leela Vyas madam to enlighten us on this session, which is very important in today's scenario. Over to you, Leela ma'am.
Thank you very much to all organizing team. Komal, she is doing very well, all medical disorders. She is choosing all. Dr. Yashodhara was telling us that there was some time when we were student, we were not getting these things because of not diagnosed timely. The reason being the diagnostic facilities were not there. So it's very good going on with these webinar. But today, first, I would like to just make aware of you that even we are going with all advancement, all these work, but still our obstetrician friends, they are getting hurted. And this is the extreme of that, which happened in my state, is that the girl committed suicide just because of the harassment. So now the time has come. We should get together. And today really I realized that it is something lacking in me also. Just to go with the academics. The girl who died, she is a very good academician. Means on that, the gold medal. The girl who is studying and still she was practically doing very well. But what happened to her life? So, Archana, you told me that, and yes, I liked that CV that should be blank. Today, I'm feeling that I'm blank. I'm nothing, not doing for my colleagues in Rajasthan. How to help them? Because there was question from others that how the Foxy can help. Because these are the things which is local, means interruption is more required. We can't blame to the Foxy that Foxy ne ye nahi kara ya Foxy ne wo nahi kara. Yes, I have worked with the Dr. Shanta Kumari, with our medical legal person, Dr. Manish, and everyone. They were saying, Dr. Vipin and all. They were saying, yes, we can provide a very good lawyer for her and all. So this is my request to all our FOXY members today, those who are joining. Please, FOXY member, all the doctors, those who are practicing obstetrics, please do join your society. Please join your social security scheme of FOXY. And this time, which we are all got done our indemnity scheme by the FOXY, that is, I think it is a very good idea, because once if anything happens, we can directly contact. Not required that कि मेरा society का secretary president क्या कहेगा, मैं खुद कह दूं. So we have to make connection with each other. And those who are not becoming member, even the obstetricians, means obstetric practice, even the MBBS doctors are doing, we have to bring together and help them. So it was all my sentiments for today. And definitely I'll say today, my mind status is not a very, means not even normal today, because since morning we are all on the roads and to giving these all presentation to the different administrative part and all. But we have to do, because always what happens, अच्छा ये हुआ, कल ये हो गया था, आज चलो, क्योंकि आज एक दिन हमने emergency बंद करी है, tomorrow we have to do all work and we have to indulge with our work and we will treat our patient as usual. We will treat all our patients attended as usual. पता नहीं कोई शायद डॉक्टर्स को एक बहुत बड़ा दिल मिलता है, we always forget, even we are losing our own persons. So topic which has been given me to is the cancer. Sorry. Cancer in pregnancy or the how many of you have seen different types of cancer? I think all those who are sitting day and day out, you must have seen, not of a very commonly cancer cases, but I have opportunity, I have seen all types of cases. I think 2 or 3 months back, which is very rare, the ovarian malignancy, because she came late and she was in a very bad shape. All metastases were there. And we approached to one of my colleagues, she got that patient, but she informed in our all with us that, so I was with her during the cesarean, so how to tackle these cases. So we all know, if even the suspicion of malignancy during pregnancy, we think that it is unexpected, unpleasant event is going with that. Definitely, we always, because we all Indian obstetricians are very sensitive towards our patients. And that's why this sensitization means sensitivity with by heart, the involvement with our patient, that also makes us weaker side on this. And that's why we are listening everyone's words, whether they are saying good or bad. But if everything is managed in a proper way, and if you have knowledge of these things, these obstetrical outcomes, both for the mother and fetus, may be just as favorable as it is for the uncomplicated pregnancy. The example which was, I'm saying that 2 months back, which the ovarian malignancy had, patient came from some outside, that was, she was having the 36 weeks of pregnancy, plus 36 plus, was approaching 37 weeks. The sonologist told us there is a marked ascites there. Immediately the ascitic fluid has been taken and it was diagnosed that there are malignant cells. So what to do? We consult with the oncologist. We all know that, yes, we have to terminate the pregnancy, but to starting with the pregnancy is to go with the cesarean. It's all precaution to train the ascites and all, then taken out the baby and then uterus closed, samples taken and then consulted. And immediately nowadays everything is okay. Then immediately the patient has been shifted to the oncology center and they have treated that patient. So when all vigilance is required, all your teamwork is required, and definitely the knowledge you should have about this. So various malignancies in pregnancy, it may be a genital or the non-genital. Genital, we all know cervical carcinoma. We are not in habit of doing pap smear during pregnancy. That's why we are not detecting. And sometimes after that we are getting, if the elderly premies, they are coming, well, multigravidas are coming, which these types of cases we have seen in our practice. So this practice we have to develop with the we should go for the pap smear during our antenatal period. Yes, ovarian, it's a rare one condition. And the ovarian masses we are getting, and so many times that some markers and all, if sonography in early pregnancy says something abnormality, definitely we are going with a detection of that, whether it is a malignant or not. Endometrial carcinoma, I think that a time has come that we should be very vigilant about that. In PCOS patient, few of the patient of my infertility patient, we have seen that there is hyperplasia is there in these. In these conditions, all PCOS patients, the endometrium should be checked very well, because in diagnostic procedure, we are just in Indian scenario, what we are doing, tuberculosis का culture based, है ना? हम उसकी proliferate histopathology is not required because we are monitoring the ovulation study in cases only by the sonography. But if on histoscopy you see that endometrium is not good, then immediately send for the histopathological examination and find out what is the condition. And this patient, one of my patient, we have treated her and she became pregnant. And then after that, we did her hysterectomy only on, because she was around 30-35 years. And after that, still she has not developed this endometrial carcinoma. In late, means after 2 years, the hysterectomy has been done and that came out as endometrial carcinoma. Then primary vulvar is a rare one. Primary vaginal, also these are the rare one. Non-genital lymphomas, leukemias, melanoma, breast and thyroid and colon. So breast cancer is one of the conditions. Leukemia, so many times in the pregnancy we used to diagnose because of the abnormal blood film. And breast cancer, because it is occurring in the early age and our pregnancy age is increasing. The girls are getting pregnant late. So some patients having treated for the breast cancer and some patients we are having even during pregnancy, we have detected the breast cancer. Other cancers, definitely we are getting referral from the other fraternity and we are going with this. So these conditions means in non-genital, we have genital, we will talk that these are the conditions which are rare one. So management plan, how to plan if a lady comes with pregnancy with cancer, the management plan should be made after informing pregnant patient or her family fully. So a proper counseling is required and the different available treatment options, we have to explain that. Definitely we should involve the oncologist in counseling part. So all medical legal aspect will be taken care. And these, regarding all these things, the first preference should be given to the patient herself. What is her wish? She wants to continue this pregnancy or she wants to terminate this. So these are the conditions that patient's involvement is very important because she has to suffer. So these are the conditions in these, the proper counseling is required for that. And can this metastasis, malignant patient can have metastasis to the fetus? Exactly this phenomena is not understood properly till date, because as far as I have found this literature, and really I am very sorry, I have not extensively gone because we are in habit of going for the last 2 days. And for last 2 days, I am busy with this. So, but the all literature they are saying, there are studies from the different centers and they are very small studies. So we can't make any consensus on that, but the studies are going on to understand whether the fetus get metastasis from that. So spread of malignancy to the fetus is a rare, except in few cases of only malignant melanoma. This is the condition where the fetus is affected. So treatment part, if it comes to that, there is a one chemotherapy or the radiotherapy. So what are the adverse effects of these chemotherapy? We all know that immediate effect, sometimes the fetal death because of that drug pharmacokinetics, premature birth, abortions, low birth weight, bone marrow suppression, teratogenicity, yes, in the first these are say. But the long term is carcinogenesis if the drug has been for last taken, growth retardation, mental retardation, definitely the sterility can be to have the mother, and then teratogenicity in the future generation. So just to understand this pharmacokinetics alteration during the pregnancy, what happens is all know the physiological changes occurs. Because of that physiological changes, the drug absorption, distribution, metabolism, and excretion, everything is affected. So in pregnancy, why it affected, and especially the drugs which is water soluble. Because in pregnancy, the total water, water increases up to the 8 liters, and plasma volume, we all know that is to the 50%. So these changes leads to the decreased peak concentration of the drug, prolongation of the half-life, and retardation of the drug elimination. And then the third space fluid, that is the amniotic fluid. This amniotic fluid, which acts as the third space for the water soluble drugs. So this increases in the apparent volume of the distribution and prolonged exposure of the water soluble drugs, and potential maternal and fetal toxicity will be more because it remains in that water content is there. We all know that the placental barrier is there. So diffusion across the placenta depends upon the molecular weight of the drug. As less the molecular weight, it will cross to the placental barrier. Plasma protein binding capacity also that lipophilicity of that drug molecule and state of ionization, how these drugs are going to use. So these are the things which the pregnancy physiological changes that affects the drug pharmacokinetics. Then again, in which trimester there is an exposure of these drugs. So trimester of the exposure, mechanism of action of the drug, how it is acting, and frequency and duration of the exposure, route of administration, whether it is, so intraperitoneal is always avoided. So this should not be, because there will be a direct effect on the uterus. So if these, then again, the one part of the treatment of this, the radiation. Radiation, why we want to avoid during pregnancy, because if it is affected in 18 to 36 days after conception, the maximum teratogenic potential occurs because of the radiation. First and second trimester involvement of CNS tissue, because we all know the CNS tissue continues to differentiate throughout that gestational period. So these are affected. So all in cases, we usually avoid radiation in different conditions where we require the radiation therapy. And I surprised to note that if we delay these radiation, especially in cases of the breast carcinomas, the progression of disease is not very fast if you have done a proper surgery in these. We were talking about that whether we are going for the pap smear or not. So this habit we have to develop that we do, especially in high-risk cases, definitely. So if any patient has been on conization, has been done any of the indication, and we found that if there is a CIN1, the next step will be just to observation. Exists that observation is required. Micro invasion, even the observation is required till you continue the pregnancy. Frank invasion, that is again depend on the patient's will. And then period of gestation, whether we go for the observation or go for the intervention of that. So if it is invasion is diagnosed before the 24 weeks of the pregnancy, again the patient's will comes whether she desired this pregnancy or she does not desire this. So if desired pregnancy, monitor all trimesters and evaluate postpartum. Pregnancy not desired, then pregnancy termination and appropriate surgery is to be done. In management of cervical cancer, if it is invasive cervical cancer in cases diagnosed 24, observe till delivery, third trimester, evaluate postpartum, and go with this. Clinically invasive cases means big mass, all stages 1B and 4, then pregnancy desire, consider the new adjuvant chemo for the bulk lesion of any stage, follow to the fetal maturity, and cesarean section staging and wait for 2 to 3 weeks before starting the radiotherapy. Means postpartum, that can be done. So these all desired or the consent which we have taken from the patients, then only we go with this. Stage 1 and B, we all know the radical hysterectomy, nodes with the fetus in situ, you take out as early as if you have, means even in the late, more than 24 hours, if you have taken out, diagnose these cases. Stage 1A and 4A to 4A, the external beam radiotherapy, weekly cisplatin can be given. And these await for the spontaneous abortion or the hysterectomy, wait for 2 to 3 weeks for the brachytherapy. So these drug treatment should be started and then you consider whether the patient's aborts spontaneous. So patient with the pre-invasive disease required at least one expert colposcopy evaluation during the pregnancy. So this habit we have to make, that pap smear, and it's not necessary whether if I'm not expert in doing colposcopy, I have to ask my colleague that those who are doing colposcopy, we should refer our patient to that. So treatment is never required during pregnancy in the pre-invasive and the early invasive diseases. We were talking about the ovarian germ cell tumors that can be safely managed with the conservative surgery and frequently do not require adjuvant treatment. So if you're suspecting that, you do surgery, as we are doing in usually in the adnexal masses, especially in the ovarian, because there is a chances of the torsion of the ovarian masses. So if it is a bigger 6 to 7 centimeter size is there, we always wait till the second trimester, because if 20 weeks, up to the 20 weeks, there is no torsion, then we have seen that even the literature says that there is a chances reduces for the torsion in the later part of the pregnancy. So if any suspected mass and it is diagnosed, definitely we have to remove, or if it looks benign, then definitely as per choice of the patient or her symptom, we can continue this. So patient with the early uterine cancer also who are on the medical therapy and becomes pregnant, so they require the evaluation of endometrium and pelvis at the time of delivery or shortly thereafter. If you are doing cesarean, definitely that time you just evaluate their extension and the pelvis and see in the pelvis any other means you feel the nodes and all conditions can be there. So appropriate operative informed consent should be obtained to allow the flexibility in surgical therapy. So if these are the cases when such uterine cancer or these suspected cases are there, or the early stages cancers are there, always the consent part. And then while doing the surgery, yes, definitely we should have one of the person who is expert in the oncosurgery, that you take help from them and then proceed for their cesarean delivery or further that treatment as required. In breast cancer, the radiations, we all know this, breast cancer cases, if you need, we all know that most treatment which is accepted is the radical mastectomy. The lumpectomy, those who have done, because nowadays we are going towards the lumpectomy. And if lump is properly excised, means the margins has been cleared, that can be done during the pregnancy and your radiotherapy can be delayed. And this is in practically every institute is following that, they are delaying this radiotherapy. So this radiation, any of the radiation, whether we are using in for the diagnostic purposes or for the therapeutic purposes, these radiation is transmitting from the internal scattered way to the fetus. So we can't avoid only putting the shield side. So small doses of radiation like the X-ray chest we are requiring, the shield, definitely we know that shield can help that. But the higher doses when we are going with that, this goes with that internally, it goes into the fetus way. And this extent of amount of radiation, this received by the fetus, this is all depend on the how far the fetus is there, which part of the body is we are giving radiation to there. Then again, that center of the field, what is the center of the field? What is the field size? And definitely the energy source which is used. So the different radiation machines which we all are talking, that linear and all, these machines which have that limitation of that. As we are doing in the all of my colleagues sitting here, they are doing this endoscopy surgery and using different energy source in different surgery, whether it is open or in the endoscopy. We all know that different energy source have the different lattice spread. Like that also the different machines, different energy source for the radiation, they have different power. So deciding to give that radiotherapy, if even it is required, then you consult the radiotherapist to ask them that what is, if this machine, by this machine and this dose we are giving, how much of that radiation can be given to the fetus, and that all informed to the patient and then proceed for these therapies. So if lumpectomy is done, radiation can be safely delayed until after delivery, because the various studies saying there is no fast progression of disease if completely excision has been done. New adjuvant chemotherapy can be given during pregnancy if it is mandatory. Hormonal therapy is not indicated during the pregnancy in breast cancer. Pregnancy after breast cancer, yes, definitely it is safe, but the effect of pregnancy on recurrence is unclear. Whether one patient completely treated. So we should delay at least 2 years after that. The lady has completed her treatment for the breast cancer, and after that 2 years, the lady can proceed for the having pregnancy. So it's there is no various studies showing that it is not clear-cut data that say that if the lady get pregnant, the breast cancer will be, the recurrence will be there. All breast cancer, leukemia, lymphoma, melanoma, and thyroid cancers are most commonly non-gynecological malignancies, which are encountered during the pregnancy. And we have seen all my colleagues, Dr. Batra is there, Dr. Mala Srivastav, and all seniors, Dr. Yashodhara and Meera Madam is there. You must have seen these all cases during your practice. They are referred from the other fraternities. As the age of the pregnant women continues to increase, the incidence of these malignancies during pregnancies are anticipated to increase. Yes, everything which we are, because the first pregnancy or even in the day are delaying for the second pregnancy in the late, these incidences increases. There remains the controversy regarding the prognostic implication and aggressiveness of the malignancy. So it's not clear-cut data whether what will be the prognosis and what will be the aggressiveness of these malignancies. So diagnostic method and treatment planning must take into consideration the risk and benefit to both the fetus and mother. So if lady coming and having these recurrence, so how to diagnose it and how to proceed with that. So everything means every step we have to go, because the time I think allotted me is only the 12 minutes. So we are not able to discuss about the different methods, but yes, the overview which I got from the literature which I am producing you. So we must consider the evidence-based data when recommending the use of innovative treatments in the pregnant patient regarding both maternal and fetal risk and outcomes. So even that those different biological markers means these new drugs which you are using must be used in these cases. I think so the different conditions which we were talking about, that the diagnosis, then to the treatment part, and then to follow the pregnancy, which again require different groups of drugs which is given to the patients is to be again noted in that. So documentation is proper and counseling should be proper in these patients. Thank you very much. No sound.
Thank you, Leela ma'am, for the lovely talk.
And
Mala
now
ma'am, would you like to conclude?
Ma'am, unmute.
Mala ma'am.
Mala ma'am, unmute करिए. Dr. Mala, आप unmute करिए.
It was an excellent presentation, Leela madam. Each word was so important regarding cervical cancer, regarding breast cancer, how to give this therapy.
Dr. Archana ma'am, would you like to conclude?
So regarding...
Unmute karo.
I think there is some problem with connection. Mala ma'am was there.
Yes, she was there.
Mala ma'am, please unmute.
Yes, madam. Pardon, ma'am? Acha. Okay. हाँ.
I must congratulate Dr. Leela madam for an elaborate and extensive scientific deliberation on cancer in pregnancy. We are seeing patients who are coming with different cancers in pregnancy. We have seen patients of osteosarcoma with the active lesion coming with 32 weeks of pregnancy. We are also seeing patients who are treated for breast cancer and coming with pregnancy. So we are dealing with such cases during pregnancy. And yes, you have really guided us how to take care of the mother and the baby. We have to balance the risk and benefit, whether we have to plan the chemotherapy, neoadjuvant chemotherapy, or diagnostic modalities. And we have to exactly counsel the patient where they stand and what are the wishes of the pregnant women, whether they want to continue with the pregnancy or whether they want termination. Management is definitely progressive. We have neoadjuvant chemotherapy, which are safe during the second trimester as well as during the third trimester. So we have to pick and choose our treatment for different malignancies, and we have to see that our patients' desire are fulfilled. If they want to continue the pregnancy, they're helped. And we also see that the treatment of the malignancy is definitely carried out well as mother's desire for carrying the pregnancy is taken care of. As an obstetrician, we have to deliver the good for both the mother as well as the baby. And of course, we have to take care of the long-term health of the mother. Definitely, Dr. Leela, you have touched many aspects of the cancer in pregnancy, and your scientific deliberation was really very elaborate and extensive. Thank you, Dr. Ruchika.
Thank you, ma'am. It was really a great insight, and thank you, the organizers, Komal ma'am, Yashodhara ma'am, and Ruchika for the honors. Thank you so much.
Yes,
Thank you,
it was.
Ashna ma'am. Thank you, Mala ma'am.
Thank you, Gabri.
I would like to invite Dr. Geeta for the next, for comparing next talk. She is gynecologist, senior gynecologist consultant at Heritage Hospital, Raipur. She is visiting consultant, Balco Medical Center, Raipur. Dr. Geeta, over to you.
Good evening, everyone. So our next topic for the day is liver dysfunction in pregnancy. And for that, I would like to call upon first Dr. Aditi Tandon. She is consultant gynecologist and fertility consultant in Dr. Sudha Tandon Fertility Center in Mumbai, Vashi. She is recipient of Foxy Young Turk Awardee in 2019, Best Youth Council member in 2019, Yuva Star Research Year 2019, and she received Ashok Mehra Prize for Best Endoscopic Paper in 2019. Welcome, Dr. Aditi. Now, I would like to call upon
Dr. Reeti Mehra, madam.
Yes. Dr. Reeti Mehra, ma'am. She is recipient of many awards, Rashtriya Gaurav Award, Fellowship in Endoscopy from Germany she has done. And she has been chairperson, Research Committee IMS, member editorial board GMH, and many feathers to her cap. She has more than 50 publications in her kitty. So I would like to invite both the chairperson to lead this session.
Thank you, Dr. Geeta.
Thank you.
And at the outset, I would like to thank the organizers for the opportunity, Dr. Komal Madam, Dr. Ruchika Garc Ma'am. And it's my privilege to introduce our next speaker for the webinar. Can we have the CV, please? Yeah, so the next talk is on liver disorders in pregnancy by Dr. Ruchika Garc. She is Professor OBGYN at SN Medical College, Agra. She is Joint Editor Journal of SAFOG, and she's on the editorial board member of Journal Midlife Health and also Secretary of Indian Menopause Society. She was in 2018-2020. And she's been a recipient of various awards, and she's also a postgraduate and MBBS examiner.
Thank you, Reeti madam. It's a pleasure you are being here, and you are also always a source of inspiration for all of us. So this liver disorder, a very good afternoon to respected seniors and friends. So this liver disorder in pregnancy, it's a very vast topic, but I would like to complete it in 20 minutes time. So this liver disorders in pregnancy, it's an important cause of maternal mortality and morbidity. So about 8% of maternal deaths can be averted because of pregnancy related liver disorders. So we just need to see all these things. So what are the various physiological changes which can mimic liver disease in pregnancy? We know that in pregnancy, there is always a hyperdynamic circulation, gallbladder is dysmotile, and clinically significant esophageal varices and spider angiomas and Palmer erythemas can be very often found. These are So how to interpret the liver function tests during pregnancy? So these liver function tests, they remain almost the same as in non-pregnant state, except for alkaline phosphatase, which is increased. So in uncomplicated pregnancy, serum bilirubin and SGOT, SGPT, they always remain in the normal range. And this alkaline phosphatase is increased because of the increase in placental isoenzyme. And we know that because of hemodilution, there might be mildly decreased serum albumin levels. So any elevation in SGOT, SGPT, serum bilirubin, or bile acids in pregnancy, it's abnormal and it requires investigation. So now coming to pregnancy-specific liver disorders. So we know that hyperemesis gravidarum, which it can occur in first trimester, for which the treatment is just supportive. Then in the last second trimester to the third trimester, we have intrahepatic cholestasis of pregnancy or obstetric cholestasis. Then in the late second trimester, we always have this preeclampsia leading to HELP syndrome and acute fatty liver of pregnancy, which occurs in the third trimester of pregnancy up to the postpartum period. So pregnancy can also occur in a case of pre-existing liver disease patients, like patients with hepatitis A, B, or C patient. So certain liver conditions, they can be exacerbated in pregnancy, like we see the instance of gallstone disease and cholecystitis and cirrhosis. So now coming to what imaging is safe in pregnancy if we encounter a patient with liver disease. So abdominal ultrasound without a contrast is the preferred imaging modality. We all know that. And we also might need to do the Doppler of hepatic vasculature, that is the portal vein, bile veins, but we should avoid the exposure, long exposure times. And if required, we can do MRI, and that too without gadolinium contrast. Though CT is also safe, but we need to avoid the contrast in CT. So elastography, it's this insufficient data to recommend is used. And if we are always concerned about breastfeeding, so if after a contrast has been used, either gadolinium or iodine, breastfeeding is always safe. So these are certain coincidental diseases which can occur in a patients with pre-existing liver diseases like alcoholic liver disease, drug-induced liver diseases, like patient might be on anti-tubercular drugs or certain other drugs. Then non-alcoholic steatohepatosis, which is the nowadays the most very common non-communicable disease. And we can also encounter autoimmune hepatitis. So now coming to chronic hepatitis B. So we need to consider whether what is the risk of mother to child transmission. So for hepatitis B, we all know that all pregnant women, they need to be screened, and majority of patients are asymptomatic and it's just incidentally detected. In advanced liver diseases, the pregnancy is usually uncommon. So these are the various modes by which hepatitis B is transmitted. Just we can revise that it doesn't spread by sneezing, coughing, hugging, and sharing eating utensils. Other modes, vertical transmission, which is the most important mode of transmission, which occurs in 90%, because hepatitis B does not crosses the placental barrier to much extent. So the prevalence of hepatitis B is about 3 to 8% in various studies. And we know that hepatitis B in long term, acute se kuch nahi hota hai. Long term, it may lead to cirrhosis and hepatocellular carcinoma within span of 20 years or more. And 65, maximum 70, 2/3 patients are asymptomatic, and only in less than 1% cases fulminant hepatitis might occur. And about 1/3 patients can land in acute hepatitis B. And we know that 70% cases of hepatitis B patients may develop into inactive carrier state. And out of this, 30% can develop cirrhosis. I mean, only 5 to 10 patients will acquire chronic hepatitis B. And out of which 70%, out of these 5 to 10% cases, 70% can develop as a carrier, and that too they will remain inactive for so many years, and out of that also 30% can develop cirrhosis. So whenever we encounter a patient of hepatitis B in pregnancy, so these are the basic battery of tests which we need to do, because we need to know the CBC, the platelet count. Whenever the liver functions are considered, we should know about her prothrombin time and the liver function test. And coexistent hepatitis C and HIV we need to rule out. And hepatitis B envelope antigen and quantitative hepatitis B DNA is very important, because that will decide our treatment modality. Of course, we need to do an USG ultrasound for the liver texture and fibroscan. The safety in pregnancy is not yet established. So we can know about the degree of fibrosis from the basis of fibroscan. So hepatitis B DNA and envelope antigen should to know the infectivity of the patient is very much required. So if the patient has hepatitis B patient had normal liver function test, then she might be in the immunotolerant phase and she is an asymptomatic carrier. And for such asymptomatic carrier, no specific treatment is required. Just we need to regular follow up them with the liver function test, because in majority of the patients, there is no risk of disease progression. And just we need to prevent vertical transmission. But if the hepatitis B DNA viral load is more than 2 lakh international units, along with hepatitis B envelope antigen positive, then there is a high risk of fetal transmission. And if the viral load is low and hepatitis B envelope antigen is negative, then there is low risk of transmission. So this hepatitis B envelope antigen is a marker of infectivity. From here, we can know that the patient, how much he is going to transmit it to the fetus. So how we can prevent vertical transmission? So we need to start antivirals. So tenofovir and lamivudine, telmivudine, these are the drugs of choice, but they should be started from the second trimester onwards after 24 weeks of pregnancy. So if the hepatitis B viral load is more than 2 lakh copies along with hepatitis B envelope antigen, there's a high risk of transmission. And the most important thing is both active and passive immunization of the newborn within 12 hours of its birth. Active immunization in the form of hepatitis B vaccine, which should be given in 0, 1, and 6 months of the age of the newborn, and passive immunization by hepatitis B immunoglobulin. But if it's a low viral load, then we need not start any antiviral therapy, but we should always start active passive immunization of the newborn. Even if the mother is HBsAg negative, then also we can hepatitis B ka immunization to baby ka kar hi dena chahiye. And hepatitis B is such vaccine that which can be given in the pregnancy also. So those patients who are not positive, they should be given hepatitis B vaccination during pregnancy also. It's safe. And the other work which we have to do is family planning. We need to give and vaccinate the whole family. And we need to find out the source, whether blood transfusion or tattoo, or whether there was a prolonged intravenous treatment in the childhood. So advanced fibrosis, if there is there, then should never stop therapy. Chronic hepatitis B का pregnancy में ज़्यादा इफेक्ट नहीं होता. Asymptomatic flares हो सकते हैं SGOT, SGPT में. तो now coming to hepatitis C in pregnancy. Hepatitis C का भी prevalence जो है 0.5 to 1.5 है. And इसका vertical transmission of hepatitis B, if not treated, is about 90%. But here the vertical transmission rate is very less. It is less than 10%. So here high viral load, or if the patient is co-infected with HIV, or if there are premature rupture of membranes, so we should avoid कि PROM हो जाए या repeated हम pervaginal examination करें या invasive fetal monitoring करें या amniocentesis करें patients में. So these things should be avoided. So these things will increase the risk of transmission. So if we'll need to do her liver function test, if the liver is normal, hepatitis C ka there is no treatment should be given during pregnancy, because antivirals are not found safe during pregnancy. After lactation, we need to treat the hepatitis C virus infection. So if there is liver function tests are abnormal, or it's a case of chronic hepatitis or compensated cirrhosis, then also we need to refer the patient to a hepatologist, and conservative management and regular monitoring should be done, and treatment should be done after the lactation as early as possible. So antivirals are not safe in pregnancy and lactation against hepatitis C. That is the crux. There is no prophylaxis, and we need to treat children who become positive after the age of 12 years. Neonate का भी we 18 months of age पे we have to test her for anti-HCV antibodies, क्योंकि उससे पहले टेस्ट करने से the baby will be having antibodies from the mother, so it will not be helpful for us. So we need to test for anti-HCV antibodies in the neonate of a positive anti-hepatitis B, hepatitis C patient at 18 months of age. And along with that, hepatitis C viral RNA titer should be done at afterwards. Likewise, जैसे कि cesarean is not recommended in case of hepatitis B for preventing maternal to fetal transmission. Here also in hepatitis C, we do not recommend cesarean for preventing vertical transmission, and even breastfeeding is not contraindicated in both hepatitis B and hepatitis C. Because what are the other issues which need to see in cases of hepatitis C? Like we need to screen their sexual partners, families should be screened, and जो हमें अपना healthcare provider को we should avoid needle stick injuries and universal precautions. Hepatitis C के लिए there is no primary prophylaxis, there is no secondary prophylaxis, there is no vaccine, there is no immunoglobulin. So personal protection is the best thing which we can do for ourselves. Universal screening should be done, but many authorities and many organizations are plus minus. And hepatitis C does not directly affect fertility, but there is increased risk of intrahepatic cholestasis in pregnancy. And during pregnancy, hepatitis C का course भी alter नहीं होता, monitoring भी नहीं require होती है, और within 12 months बहुत सारे patients spontaneous resolute भी कर सकते हैं. So before starting treatment, we need to recheck the patient again. So peripartum is the time when there is highest risk of transmission to the fetus, and of course intrapartum and postpartum are there. But if there is co-infection with hepatitis C with HIV, then risk of maternal transmission is almost double compared to the patient who are only hepatitis C positive. Then these are the chronic hepatitis forms. Sometimes we can also encounter patients with acute viral hepatitis. So for acute viral hepatitis, generally herpes simplex virus and hepatitis E virus, they can turn as acute viral hepatitis, and also CMV and Epstein-Barr virus hepatitis are also sometimes seen. Hepatitis E ke baare mein we know that it's by fecal-oral route, and in the second and third trimester, there is increased severity and severe disease. And here the case fatality rate for the neonate is 8%, and fetal mortality is also very high, and maternal mother to child transmission is also 33 to almost 100%. Hepatitis E का भी कोई specific treatment नहीं है, only symptomatic treatment we have to give. We have to give antiemetics, antacids, if encephalopathy likewise. And because these drugs, ribavirin and interferon alpha, they are contraindicated in pregnancy. और इसमें when we investigate, the patients may encounter very high serum bilirubin, SGOT, SGPT, thousands में जा रहे होंगे. और in pregnancy में इसका outcome is also not good. There are more chances of premature membrane rupture, there are more chances of abortion, stillborn, and of course maternal mortality. So we can always give a supportive treatment, but if the patient का oral intake कम हो गई है, vomiting हो गई है, तो then we might need to hospitalize her. Or if there is coagulation related bleeding, or she might go into altered sensorium. But we can never know the prognosis from the level of bilirubin, SGOT, SGPT, because these are very misleading in case of hepatitis E infection. So how to prevent this thing? Hepatitis E, washing hands, filtered boiled water, washing fruits and vegetables, sewage disposal, and proper hygiene defecation habits, and public education, of course, is a key. So herpes simplex virus, it's also very much sometimes undiagnosed, but it is an important cause of disseminated disease. Here, rash is present in only 20%, but it might just present with direct fever and encephalopathy and coagulopathy, and we know that acyclovir is the treatment of choice. But if there is fulminant liver failure, then liver transplantation may also be required. Sometimes autoimmune hepatitis can also be encountered in practice. Here, the fetal losses, up to 1/3 patients may lose their patients, and mortality is also very high. Now coming to non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease का PCOS से काफी association है, और इसमें काफी complications pregnancy में we can get, like GDM, hypertension. And we know that nowadays the incidence of obesity is increasing in. So maternal obesity and diabetes are very predisposing factors for non-alcoholic fatty liver disease. Fatty liver is so much common. So breastfeeding, it decreases the risk of non-alcoholic fatty liver disease in children and leads to reduced maternal metabolic complications. So ऐसे patients में weight gain proper होना चाहिए, कोई medications approved नहीं है, just non-pregnant patient की तरह we need to monitor the patient. Or preconceptional counseling on optimization of weight is the only thing which is in our hand if the patient with non-alcoholic fatty liver disease presents to us. So alcoholic fatty liver disease west में इसका काफी इसका incidence है, इससे भी small for gestational age and preterm babies काफी होते हैं. And we should, if they come for preconceptional counseling, we should advise them to delay their conception until and have abstinence, and medication should be individualized. Now, other which liver masses which we can get hepatocellular adenoma. So hepatocellular estrogen dependent होते हैं ये. If less than 5 centimeter, अगर हमारे पास preconception period में आते हैं तो we will not advise them pregnancy. अगर less than 5 centimeter है तो then we will first treat it, and we need to counsel her regarding the increase in size and rupture. अगर 5 centimeter से ज़्यादा है तो then we need to do bland embolization. In the treatment we need to do. Pregnancy and cirrhosis भी कभी-कभी मिल जाती है. इसमें भी it's quite a risky condition where maternal mortality from 20 to 20% is there. क्योंकि एडवांस स्टेज सिरोसिस है तो फर्टिलिटी अपने आप ही कम हो जाती है. Now coming to the most important topic, which is intrahepatic cholestasis of pregnancy, which we very often encounter. So those patients who develop ICP while they are on OCPs, oral contraceptive pills, because it also has a strong family history and a genetic predisposition. Those patients who have advanced maternal age, multipara, and metabolic syndrome, they have more chances of intrahepatic cholestasis of pregnancy. So the symptom is generalized pruritus, and most severely at the palms and soles, and most commonly present in the later halves of second trimester. So the diagnosis is based on serum bile acids, but many times we are not able to do the bile acids, and bile acids the critical range at more than 10 micromoles per liter. But if we are not able to do the bile acids, just we can on the basis of symptoms. Here the serum bilirubin and SGOT, SGPT might be elevated, but they are not too much elevated. Here sudden intrauterine fetal deaths are very common, so we need to be very vigilant, and bile acids should be ideally monitored. And so here delivery is indicated around 37 weeks of pregnancy. Here preterm birth, meconium stain liquor, neonatal respiratory distress syndrome are very common, and symptomatic pruritus can lead to rash and ulcers also. And जिन पेशेंट्स को होती है उनको फ्यूचर गॉलस्टोन या सिरोसिस या बिलियरी फाइब्रोसिस होने की चांसेस होती हैं, एंड पोस्टपार्टम में ये अपना आप रिजॉल्व हो जाती है in the after the second week. So the most important take home point from this is sudden intrauterine death and meconium stained liquor is very common. So we need to induce these patients at around 37 weeks of pregnancy. And by no way we can predict that in which patient's adverse perinatal outcome or intrauterine death is going to happen in patients with obstetric cholestasis. So we know that ursodeoxycholic acid in doses of 10 to 15 microgram per kilogram body weight, it improves symptomatic treatment. Along with then we can give levocitrazine or topical emollients for relief of the patient. So it's the first line therapy. लेकिन ये fetal complications कम करेगी कि नहीं करेगी, that we don't know. What we know is कि इससे pruritus और symptomatic relief मिल जाएगा. इसके लिए cholestyramine और other things are also given, but practically we prefer giving only ursodeoxycholic acid, and vitamin K might also be given depending on the prothrombin time. So about HELP syndrome, we know that the only treatment available is delivery. And now the other complication is acute fatty liver of pregnancy. So it is a very deadly complication, and it's a good thing. It's a very rare medical and obstetric emergency, and it is due to the deficiency of mitochondrial long chain dehydrogenase deficiency in the fetus. So these get accumulated, and these metabolites, they enter from the fetal to the maternal circulation. For that, Swanson criteria are there. अगर 6 से ज्यादा criteria fill हो जाए, like vomiting, abdominal pain, polyuria, polydipsia, high serum bilirubin, hypoglycemia, high uric acid levels. So here, newborns, they should be treated with dietary modification with reduced and expeditious delivery post-stabilization. Here, maternal mortality is also quite high, up to the range of 1 in 10 women die due to acute fatty liver of pregnancy. One word about liver transplantation in pregnancy. Liver transplant recipient को 1 year wait करना चाहिए before trying to conceive, and because these patients are on immunosuppressants and these mycophenolic acids, they are contraindicated in pregnancy. Here, maternal mortality rate is though not increased, but these patients have high risk of GDM and hypertension and PIH. PPH is also there. Assisted reproduction technique can we do in patients with liver disease? Of course, we can do, but we need to counsel the patient regarding the degree of hepatic decompensation. And as I've already told, that fertility rates are similar in general population in patients with compensated cirrhosis, लेकिन decompensated cirrhosis में already 40% fertility rate कम हो जाती है, तो वो advanced stage cirrhosis वाले patient conceive ही कम करते हैं. So take home message is what is कि we need to vaccinate the child, and we need, in cases of hepatitis B, within 12 hours of birth, and we need to do the viral load of the patient for knowing the maternal to fetal transmission rates. If the viral load is less than 2 lakhs international units in hepatitis B patient, there is rare risk of transmission, then we need not start antiviral therapy. Otherwise, tenofovir and telmivudine should be started. Cesarean should be done only for obstetric indications. If you want to do any invasive procedures, risk benefit should be advised. In both hepatitis B and C, breastfeeding can be given. And we need to be very much vigilant in cases of hepatitis B pregnancy, and ideally estrogen is metabolized, so estrogen containing contraceptives should be avoided, and if we can use any long-acting reversible contraception, they should be given. Counseling is the key, and treatment should be individualized. Thank you for your patient hearing.
Wonderful presentation, Dr. Ruchika. It was a great talk, and beautifully covered everything. And it is a very, very important topic because cholestasis particularly is rising really, especially in North India. And we are getting to see more and more. It used to be 1 in 400, 500. Now we are almost seeing to the tune of 10% at least in referral centers at our hospitals. I would just like to make a few comments. Bile acids are known to cause IUD, just to stress, irrespective of the degree of SGOT-PT, and they are known to cause increased PR interval in the fetus, and they get into the cardiomyocytes of the fetus to cause IUD. So it is said that you have also said that one should terminate patients of cholestasis at about 36 to 37 weeks, depending upon, you can either do the bile acids more than 50, 40. They say in many papers it has come that if it's more than 40 milli-international units, good idea would be to terminate the pregnancy. And one more thing, pancreatitis is a very, very important complication of acute fatty liver of pregnancy. So even in acute fatty liver, if we are suspecting, we should deliver these patients, and it will have a better outcome. So sometimes even if the patient is not completely stable, we do induce labor in acute fatty liver of pregnancy because complications and mortality rates are very high. So with that, I think we can open the house for discussion. Fantastically taken lecture, Ruchika. And you've covered some really rare conditions like adenomas and NFLDs, which one does, and I'm so happy that very comprehensively covered all topics. Very nice. And it's an honor to be, and I must thank the organizers for giving me this wonderful opportunity to be part of the academic discussions.
Thank you, madam. It was honors were ours.
But today is indeed a black day, and everybody's really off. Dr. What happened with Dr. Archana Sharma has affected all of us somewhere.
Yeah.
Today, I think.
Yes, really.
Yes.
Wonderful talk, ma'am.
Now, for our next session, a case discussion on peripartum cardiomyopathy, I would like to call upon Dr. Vidhu Modgil. She is a consultant and director in Suman Hospital, New Life Infertility and Research Center. She is recipient of many awards like Best Student Gold Medal in Surgery, Nari Shakti Award. She has organized many workshops. So now I call upon Dr. Vidhu Modgil to take charge of this case discussion.
Hello, good afternoon.
Yeah. Kavita madam has joined.
Yes, I am here.
Okay, thank you, madam.
Good afternoon to one and all. On behalf, I'd like to thank Dr. Yashodhara, Ruchika, and everyone for giving us this platform. And I would like to introduce Dr. Kavita for this nice topic which we have chosen, peripartum cardiomyopathy. Dr. Kavita, she is a very well-known figure in Ludhiana. She's a consultant and professor at CMC. Can we share her slide, please?
Yes, 1 second, ma'am.
Yeah, thanks. She's professor and head of Department of OB and Gynae in CMC. And she is basically a very active member in our Ludhiana Obstetrics and Gynae Society. We just now had a North Zone, and she organized one Well Women workshop in it. And she is always, and she's a very great academician and has so many credits to her name. I welcome her to take the session.
Thank you, Dr. Vidhu, for such a kind introduction. And it's my privilege that you are chairing my session. Can I share my slide, please? Can you see my slides?
Yeah.
Okay, so at the outset, I would like to thank the organizers, Dr. Koval Chal ma'am, Dr. Ruchika Garc, for inviting me for a talk in this academic program. So my topic is a case discussion on peripartum cardiomyopathy. This was a 38-year-old woman, a multiparous lady who delivered vaginally. When she presented to us, it was on the 6th day of after delivery. And she complained of shortness of breath and had some chest discomfort for the last 2 days. When we examined her, she was afebrile but orthopnic. She had mild pallor. Her respiratory rate was 34 per minute. Along with this, she had tachycardia and a low blood pressure of 100 by 60 millimeters of mercury. Laboratory investigations were sent on admission and a pro-PNB level was 17,062 nanograms per liter. Rest of the laboratory investigations were within normal limits. When we did a chest X-ray because of the breathlessness that she had, at admission, the chest X-ray revealed cardiomegaly and pulmonary edema. She was taken up for echocardiography, where we found the ejection fraction to be 30%. Features were suggestive of congestive cardiac failure. There was also regional wall motion abnormalities, and there was also a 5 millimeter thrombus at the apex of the heart. She had progressive increase in respiratory distress due to worsening of the heart failure. We gave her supportive management. She was put on the bed in a propped up position. We gave her oxygen, inotropic drugs were started, parenteral diuretics were given, beta blockers, and ACE inhibitors. Obviously, she was in the cardiology unit and she improved within 3 weeks. And the left ventricular ejection fraction returned to its previous level within 3 weeks. And after 1 year of follow-up also, she's in a positive state with no residual left ventricular dysfunction. So coming to the topic of peripartum cardiomyopathy, it is not a very precisely defined entity. But when you find a reduced ejection fraction less than 45% in a lady who's pregnant towards the last trimester of a pregnancy, or in the months after delivery, they usually say 5 months after delivery, without any previous known cause of structural heart disease, then you should think in terms of cardiomyopathy. So these are the diagnostic criteria. One is the development of heart failure in the last month of pregnancy or within 5 months postpartum, absence of an identifiable cause for the cardiac failure, absence of any structural abnormalities in the heart prior to the last month of pregnancy, and echocardiographic findings where the left ventricular end diastolic dimension is more than 2.7 centimeter per meter squared, M mode fractional shortening of 30% or less, and a left ventricular ejection fraction less than 45%. The incidence of peripartum cardiomyopathy is again not very clear. Population-based estimates are not available, and the diagnosis of the disease is rare and not very straightforward. But the currently accepted estimate, this is according to the US, 1 per 3,000 to 1 per 4,000 live births. You can see this complication during pregnancy or postpartum. This incidence may be higher in developing countries. What are some of the risk factors? One is advanced maternal age. So if a lady is more than 30 years of age, there's more common. More than 50% of cases are found in this age group. Multiparity, multifetal pregnancy, preeclampsia, gestational hypertension are other risk factors, and it is common in the African American race. What is the pathogenesis? Again, it is unclear. Possible causes may include myocarditis, placental angiogenic factors, abnormal immune response to pregnancy, maladaptive response to the hemodynamic stresses of pregnancy, stress-activated cytokines, and some of these cases are having familial dilated cardiomyopathy, which gets unmasked during pregnancy. But the current hypothesis, it directs a two-hit model for the pathogenesis of peripartum cardiomyopathy. So this is in the form of a vascular insult, which is caused by antivascular hormonal effects of late pregnancy and the early postpartum period. This induces cardiomyopathy in women with an underlying genetic predisposition. So in patients who are genetically predisposed, who suffer a vascular insult, forms the two-hit model of developing cardiomyopathy. Secretion of prolactin by the anterior pituitary gland causes upregulation of the endothelial microRNA. Placental secretion of soluble FMS like tyrosine kinase receptors, they also lead to endothelial dysfunction and cardiomyocyte death, which may also lead to peripartum cardiomyopathy. And we know that prolactin levels are higher in the last The presentation of peripartum cardiomyopathy is usually in the postpartum period, mostly in the week after delivery. A small subset of patients may present in the second and third trimesters. So this is basically because of the increase in the cardiac output, which is maximum in the last trimester of pregnancy and in the first 1 week after delivery. So how do we diagnose peripartum cardiomyopathy? This is basically on the echocardiographic findings, where you see a new left ventricular systolic dysfunction during the period surrounding delivery. Symptoms identical to early congestive heart failure are present. And many times, if you are not very vigilant and thoughtful about this entity, PPCM may go unrecognized, leading to underestimation of the true incidence of PPCM. Typically, patients present with symptoms of heart failure, like dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, edema of the lower extremities, pulmonary crepitations, new murmurs around the atrioventricular valve, and mostly the regurgitative murmurs. Less commonly, the patient may present with cardiogenic shock and sometimes with symptomatic or even unstable arrhythmias, and occasionally with arterial thromboembolism. On physical examination, the signs of heart failure would be present, like tachycardia, elevated jugular venous pressure, pulmonary rales, and peripheral edema. Signs of left ventricular dilatation, like third heart sound and displaced apical impulse. ECG would show sinus tachycardia with non-specific changes, and a chest radiography, as seen in our case, cardiac enlargement and pulmonary edema. Catastrophic presentations can also occur with severe respiratory distress, low cardiac failure, necessitating pharmacological and mechanical support. So sometimes these patients come to us in a very late presentation, and they may require intensive monitoring and treatment. Diagnosis is always by exclusion, and we need to rule out other causes of heart failure. So this requires echocardiography. So how do we diagnose on echocardiography? If there is left ventricular dysfunction with LVF less than 45%, but this is not always the case. There could be left ventricular dilatation without any hypertrophy. If the heart is globally has decreased contractility, there could be a mural thrombus, mitral or tricuspid regurgitation, and pericardial effusion. Sometimes there may be right ventricular dilatation and dysfunction with pulmonary hypertension, left atrial or biatrial enlargement, functional mitral and tricuspid regurgitation, and intracardiac thrombus, as mentioned earlier. If we do an ECG, there are no pathognomic changes which would suggest peripartum cardiomyopathy, but most commonly what we see in the ECG are changes like left ventricular hypertrophy and ST-T wave abnormalities, complications such as atrial fibrillation and flutter, Q waves in anteroseptal leads, prolonged PR and QRS intervals, and sometimes bundle branch blocks can also be seen. Other imaging technology can also be used, but this is rarely used because most of our diagnosis is based on echocardiography. So we can do a cardiac magnetic resonance imaging, which may help in confirming the diagnosis. Tesla, but again, the guidelines, according to the European guidelines and the American guidelines, are discouraged because of the use of gadolinium, which is not safe during pregnancy. Computed tomography imaging will help in ruling out other causes of dyspnea in the peripartum patients. Endomyocardial biopsy is generally not used but it can be used in cases where you suspect a giant cell myocarditis or cardiac sarcoidosis. Differential diagnoses are many. Some of them are the pulmonary causes like pneumonia, pulmonary embolism, acute pulmonary edema from prolonged tocolysis. So one should be very careful if you're giving tocolysis for a prolonged period of time. It may lead to pulmonary edema, which can mimic peripartum cardiomyopathy. If there is severe preeclampsia, we know that they are prone to pulmonary edema, which can again cause a problem in diagnosing peripartum cardiomyopathy. Cardiac causes like myocardial infarction or Tarpo to Subo cardiomyopathy, also some of the differential diagnosis. Obstetrical complications like amniotic fluid embolism can also be a diagnostic dilemma when you're considering peripartum cardiomyopathy. So what happens if a patient develops peripartum cardiomyopathy? 50 to 80% of women will recover to normal range level ventricular systolic function. That is, the left ventricular ejection fraction may be 50% or more. And most of this recovery occurs within the first 6 months after delivery. And because this improvement in outcomes actually reflects an increased recognition of peripartum cardiomyopathy, now we have started recognizing this as a disease entity, and it is easily diagnosed along with our cardiology unit. And also because there are advances in the management of heart failure, so therefore the prognosis seems to be better. How do we predict recovery? Left ventricular size and ejection fraction are the two diagnostic features which will strongly predict left ventricular recovery. So if the LVF is less than 30% and the left ventricular end diastolic diameter is more than 6 centimeters, then it is an indication that it is a decreased likelihood of left ventricular recovery. And there's increased chances of that the patient will require mechanical support, increased chances of maternal mortality are there. Right ventricular function at the time of diagnosis will also predict myocardial recovery and the clinical events which may occur according to during the course of the disease. So this is like one should remember that echocardiography should not be a one-time investigation for the diagnosis of peripartum cardiomyopathy, but we need to monitor the progress of the disease also, even after the patient recovers. So this should be done at discharge from the hospital, then at 6 weeks postpartum, at 6 months postpartum, and then annually. It should be repeated. What are some of the complications? There are two dreaded complications of peripartum cardiomyopathy. One is the thromboembolism, which affects 6.6% of women. And it usually occurs in the left side or the right side, can occur in both. Mechanisms underlying intracardiac thrombosis is basically because of cardiac dilatation, hypercontractibility of the cardiac muscle, which leads to blood stasis. Also, it can be because of the endothelial injury. And we all know that pregnancy is a hypercoagulable state, which is due to increased levels of the factors 7, 8, 10 fibrinogen, and sometimes von Willebrand factor may also aggravate the formation of thrombus. Decreased protein C and S activity and decreased fibrinolysis, all these changes will normalize by 6 to 8 weeks postpartum. So the patient is more prone to thromboembolism during delivery and after delivery also up to 6 to 8 weeks. Arrhythmias can occur in these patients, which can lead to sudden death from ventricular tachyarrhythmia. Now, coming to the management, the basic management of peripartum cardiomyopathy is the treatment which we give for any heart failure where there is reduced ejection fraction. So the treatment should include sodium restriction, which will help to reduce the volume, the circulatory volume. A diuretic can be added to decrease the preload and pulmonary congestion or edema. You need to give beta blockers because beta blockers will cause the heart to beat more slowly and more effectively, so that a greater chance of recovery of the left ventricular ejection fraction is there. Angiotensin converting enzyme inhibitors and angiotensin receptor blockers are basically used for neurohormonal blockade. Hydralazine and nitrates may be used for vasodilator therapy. We need to pay careful attention to all these drugs because these drugs, if given in an antepartum period, may have adverse effects. and also during the postpartum period, because this is the time when she is feeding the child, breastfeeding the child. Always the management should be collaborated along with the cardiologist, perinatologist, and neonatologist. So these patients should be treated in a tertiary care hospital, better to refer once diagnosed. We need to give inotropic support, dopamine and butamine in cases of severe low output. And as soon as the patient is stable, then we need to wean this off. Levosimendan, this is a newer drug, which is a calcium sensitizer, and it enhances the cardiac contractility and also leads to vasodilatation. So it reduces the pulmonary capillary pressure and improves the cardiac output. And since pregnant women are systemically vasoconstricted, vasopressors such as noradrenaline are usually avoided, especially antepartum. We need to give anticoagulation because they are prone to develop thromboembolism, and heart failure and pregnancy are also independent risk factors for thromboembolism. So we need to administer low molecular weight heparin or heparin, and warfarin we know needs to be avoided, especially because the patient may be unstable. But these drugs are recommended when the left ventricular ejection fraction is less than 30%. According to the European Society of Cardiology guidelines, anticoagulation in patients with peripartum cardiomyopathy is given when the ejection fraction is 35% or less, and especially patients who are taking bromocriptine. I'll come to this bromocriptine, why it is required in peripartum cardiomyopathy. According to the American Heart Association guidelines, they consider anticoagulation in women with peripartum cardiomyopathy where the ejection fraction is again less than 30%. But we need to anticoagulate all women with cardiomyopathy until 8 weeks postpartum. One should remember that warfarin crosses the placenta, is teratogenic, but can be given during postpartum when she is breastfeeding. Antiarrhythmic drugs may be required. Sometimes we need to do cardioversion and defibrillation in certain emergencies, and mechanical circulatory support may also be required in severe cases. Before we go on to transplantation, some other methods can also be applied, like intra-aortic balloon pumps and left ventricular assist devices, which I'm not very familiar, only our cardiology friends may help us in this situation. Immunosuppressive therapy can be considered if an endomyocardial biopsy indicates myocarditis and if there is no improvement after 2 weeks of standard heart failure therapy. So these are some of the advanced treatment which may be required in certain cases of peripartum cardiomyopathy. We are interested in the obstetrical management, so it should always be a multidisciplinary team where we involve the anesthetist as well as the cardiologist, individualize each treatment, each patient treatment, and include the cardiology and the anesthetist when we are deciding about the timing and mode of delivery. If a patient becomes stable with medical therapy, again under the supervision of the cardiologist, we can continue the pregnancy with very close monitoring, and the patient needs to be admitted for this. Cesarean delivery should be considered in cases of acute heart failure according to the European and the American guidelines, but it is otherwise reserved for only obstetrical indications. Epidural anesthesia is safe, and assisted second stage in case you're delivering vaginally, vacuum or forceps would help. What about subsequent pregnancy? So whether the lady should have another pregnancy after she's had peripartum cardiomyopathy in the current pregnancy. So the ejection fraction is the strongest predictor of outcomes. And if in case the ejection fraction does not normalize, then we tell the woman that she may have very poor outcomes in subsequent pregnancy, and it is best to avoid a future pregnancy. Women with normalized left ventricular ejection fraction who want a subsequent pregnancy, it has been seen that there was a 20% risk of deteriorating left ventricular function, which may persist long-term in 20 to 50% of women. So the guidelines advise that repeat pregnancy is contraindicated in women with peripartum cardiomyopathy who have not recovered a normal left ventricular ejection fraction. Some of the emerging treatments which I was earlier talking about are the prolactin inhibitors like bromocriptine and cabergoline, because in my earlier slides when we talked about pathogenesis, it has been seen that prolactin may be one of the pathological factors, and because inhibition of prolactin may lead to therapeutic and preventive measures. Therefore, bromocriptine and cabergoline are some of the newer drugs which are being tried for the treatment of peripartum cardiomyopathy. But we still need to do prospective randomized controlled trials before we can recommend this treatment. Now, patients who have had a history of peripartum cardiomyopathy and they plan another subsequent pregnancy in case the left ventricular ejection fraction comes to normal. So in those patients also, you need to counsel them and perform frequent clinical examinations and serial echocardiograms. So this was a protocol which was proposed recently. How many times of echocardiography you need to do in the subsequent pregnancy if the previous pregnancy there was a peripartum cardiomyopathy. So one needs to be done before delivery or before conception, sorry. Then at the end of first trimester, again at the end of second trimester, 1 month before delivery, after delivery, soon after delivery, and then 1 month after delivery. So these are the timelines of pregnancy where echocardiography will be required for a patient and monitoring of the cardiac status in the patient who conceives in a subsequent pregnancy. These are some of the recommendations again for future pregnancy after PPCM. Though there is no consensus, but patients whose left ventricular size or function does not return to normal should be counseled strongly to avoid future pregnancy. Advise them a healthy diet and lifestyle. Patients whose cardiomyopathy apparently resolves completely are more difficult to counsel because they do not take our advice of not having another pregnancy or baby. So again, counseling is very important in these patients because the risk of irreversible cardiac damage is always there, and impaired contractile reserve may increase with each subsequent pregnancy. So the risk of morbidity and mortality, risk of peripartum cardiomyopathy increases with each pregnancy. So they should be made well aware of this. PPCM is a rare disease of unknown cause. It may recur and is associated with high mortality rate. It is challenging to diagnose and to treat and requires absolute vigilance. The primary goal of therapy is to alleviate the symptoms of heart failure. If the left ventricular size returns to normal, the short-term prognosis is favorable, but long-term sequelae, we are not very well aware of it, and repeat pregnancies may cause subsequent peripartum cardiomyopathy in subsequent pregnancies. So failure of heart size to return to normal is associated again with excess morbidity and mortality. Role of bromocriptine as a therapeutic agent is currently experimental. And if we are giving bromocriptine, we need to give anticoagulation along with it because bromocriptine is prothrombotic and it may suppress lactation. Early delivery or termination of pregnancy should be considered in cases of hemodynamic instability. Stable patients are delivered vaginally, cesarean section only for obstetrical reasons, or in cases of acute failure, postpartum risk of decompensation should be anticipated. And because of the high prolactin levels, which is thought to cause peripartum cardiomyopathy, one of the causes of peripartum cardiomyopathy. So some of the guidelines, especially the European guidelines in 2010, they advised against breastfeeding, but this is not recommended by the American guidelines. And it is always advisable to for women with new onset PPCM and severe left ventricular dysfunction to have defibrillators until recovery or until an implantable cardioverter defibrillator is indicated in these patients. Contraception is very important. This can be given in the form of progesterone releasing subcutaneous implants or Mirena. Intrauterine devices, these are the first choices. Estrogen should be avoided. If left ventricular dysfunction persists, medications have to be continued indefinitely, and in those who recover, continued therapy may still be required. Additional pregnancies, again, counseling is very important. And women who recover to ejection fraction of more than 50% still have an increased risk of heart failure. And this may even persist after pregnancy into future. So during subsequent pregnancies, women with PCM should be closely monitored, as I said, with echocardiography, clinical assessments, and always advise contraception and angiotensin converting enzyme. If these patients are on these ACE inhibitors or blockers, then these needs to be discontinued prior to conception and restarted after delivery. Thank you very much.
Very well presented, Dr. Kavita. I think so. This is a rare complications which we can see, but in present times, when I think after seeing Dr. Archana's Sharma, what we are dealing with, these kind of, if you have a patient of some kind, this should be managed in a tertiary center. Facilities to take care of a heart. And plus, when we were taught in medical colleges, that whenever even a primary comes to you, you should always do a general physical examination, especially the heart should be auscultated at mid-trimester, 24 to 26 weeks, because certain kind of heart problems do reveal at that point of time only. But otherwise, very well presented. And thank you all the organizers for giving me this opportunity to chair this session.
Thank you, Vidhu madam. So, Kavita madam ka CV display ho raha hai. I think we were not able to introduce her. She is professor and head of department CMC.
It's all right, Dr. Ruchika. I think we are way behind.
Yeah. Thank you, madam. Thank you, madam. It was so elaborate and we learned a lot.
Absolutely.
First time I could.
ये बहुत कम चीजें discuss होते हैं ना, so this was a very informative session. And
yeah,
I also
it is
learned a
more
lot.
like it is diagnosed and treated by the cardiologist. So I also came to know things which were very new to me when I was preparing this.
Yeah, and how to differentiate between a pericardium and myocarditis and other kind of heart and all. I also read about it, so now I can be a more wiser person.
And minimum 5 echocardiography at what duration of time we should do.
But I think so once we know that this patient had a problem in her previous pregnancy, she should be dealt in a tertiary center. That is much better rather than dealing her at a primary health care.
Yeah, sure. Thank you, madam.
In COVID times, in COVID times, we are getting a lot of cardiomyopathies. Maybe I don't know due to COVID or maybe because of vaccination.
Yeah, myocarditis. We also came to know many cases post COVID also.
Yes. Yes.
So that's another learning for us. People who have had COVID, we should be a little more careful with them.
Yes. Okay, so for the next session on deep vein thrombosis in pregnancy, I would like to call upon Dr. Aruna Nigam. She's head of the department HIMSR Delhi, and she has an established endoscopic unit over there. She's editor-in-chief of Pan-Asian Journal of Obstetrics and Gynecology. She's national corresponding editor, Jogi, and editor of 4 books. So she has more than 200 publications in Kitty. I would like to call upon Dr. Aruna Nigam for this session on deep vein thrombosis in pregnancy.
So, thank you, madam, for such a nice introduction. I think we should be moving towards now introducing Dr. Archana. So, Dr. Archana is an assistant professor at All India Institute of Medical Sciences, and she's a gold medalist in the undergraduate, and she has done her undergraduate and postgraduate from Lady Hardinge Medical College, and she has done the SRship also, and a very good student and now a colleague of mine. And she's a winner of Foxy Traveling Fellowship Award 2016, and she's a winner of prestigious CS Dawn Award also, and he has 25 publications and continuously involved in the research work. I really admire her work. So Dr. Archana, kindly do the justice with the subject.
Yeah, thank you so much, ma'am. Thank you for your kind words. And I would like to share my screen. Are my slides visible?
Very much visible.
Okay, so I'm starting now. So the topic is prevention and treatment of thromboembolism in obstetrics. To begin with it, we had recently had a case. I'll just describe it in short because we have very little time, and I'm sure that all of us are too tired at the end of this session. So I would be really crisp with my presentation. So a 30-year-old para-2 live 0 patient presented to us at day 18 of her delivery, which was a preterm IUD vaginal delivery. And she had multiple episodes of secondary PPH. And she was referred from Maulana Azad Medical College with secondary PPH with inferior vena cava thrombosis, with moderate anemia, with intrauterine balloon tamponade, with vaginal pack in situ. She delivered 6 months back at a private hospital, and there was query abruption, following which she had multiple episodes of recurrent postpartum hemorrhage, and she received multiple blood transfusion for that. At the 4th episode of bleeding, patient underwent for evaluation at Maulana Azad Medical College, where she received blood and underwent a detailed radiological evaluation where the ultrasound Doppler ruled out arteriovenous malformation. However, it was suggestive of external iliac vein thrombosis, and so it was confirmed by CT angio, which revealed inferior vena cava thrombosis along with the external iliac vein thrombosis. So she was started on low molecular weight heparin, but after 6 days of initiating the low molecular weight heparin, she had 5th episode of bleeding of around 1 to 1.5 liter, and so a balloon tamponade with vaginal packing was done, and after blood transfusion, the patient was referred to AIMS. At AIMS, we got her CT angio done, and feeding uterine bleeders were seen, and so the patient underwent uterine artery embolization on the same day. And the CT angio also revealed that there was complete canalization of the IVC thrombus, and it was not visualized. And the bleeding stopped after uterine artery embolization. So balloon tamponade was deflated after 24 hours, and the vaginal pack was also removed. And after 1 week of having no bleeding, the patient was restarted on low molecular weight heparin along with tap warfarin, and then switched over to oral warfarin after achieving the target INR between 2 to 3. So this was the baffling case, which somehow with great difficulty balancing between the risk of bleeding and the risk of thrombosis. So, so to begin with, how do we define deep vein thrombosis? It's of course the formation of blood clot in the deep veins, the common sites being the deep leg veins, or it can be the deep veins of the pelvis. However, pulmonary embolism is a condition which occurs when the thrombus gets dislodged and it obstructs the pulmonary vasculature. It is the consequences are primarily hemodynamic, and it is apparent when already there is 30 to 50% occlusion of the primary arterial bed. So it is important to suspect pulmonary embolism as soon as possible. So why there is increased risk of thrombosis during pregnancy and the postpartum? Because all the three virtuous triad are fulfilled in pregnancy and the postpartum. There is stasis, that is, there is impression of the iliac veins. There is compression of the iliac veins by the right iliac artery. The gravid uterus presses on the veins, and of course, the hormonally mediated venular dilatation occurs along with the immobilization, which may occur because of the postpartum symptoms or during pregnancy because. Furthermore, there is hypercoagulable state because of increase in the procoagulant factors, decrease in the anticoagulant activity, and the decrease in the physiological activity. And of course, the vascular damage, which is related to delivery, is also one of the reasons for the increased risk of thrombosis during pregnancy. And of course, the incidence, though in our country is not very high, the incidence is around 1.1 per 1,000 deliveries, and the risk is increased 4 to 5 times more in pregnant than in non-pregnant women. So when should we do the risk assessment for deep vein thrombosis? We should do it in early pregnancy, or better in pre-pregnancy stage. We should repeat it if the woman is admitted to the hospital for any reason, and we should repeat it again in the intrapartum or in the immediate postpartum status. So how do we do the risk assessment? We have the scoring available for scoring of the doing the risk assessment for venous thromboembolism. So the red ones are the high risk category, and the orange ones are the intermediate risk category, and the yellow ones are the risk factors. So if the combined score is more than equal to 4 antenatally, then we consider thromboprophylaxis beginning from the first trimester. If the score is 3 antenatally, then we consider thromboprophylaxis from 28 weeks. If the score is more than equal to 2 postnatally, we consider thromboprophylaxis for at least 10 days in the postpartum phase. And if at all the woman is at hospital, then we consider thromboprophylaxis. So we start antenatal prophylaxis with low molecular weight heparin. For the intermediate risk factors, we consider antenatal prophylaxis. And if there are 4 or more of the yellow risk factors, then we begin prophylaxis from the first semester. But if there are only 3 risk factors, we begin the thromboprophylaxis from the 28 weeks onward. And of course, we should not forget the pregnancy. It is a transient risk factor for thromboembolism in pregnancy in this. Now, at the time of postnatal, we should again do the risk assessment, and all high-risk patients should have received anticoagulation for at least 6 weeks in the postpartum phase, and the intermediate risk should have at least 10 days of postnatal prophylactic low molecular weight heparin. And if 2 or more of the risk factors are present, then they can continue for 10 days of prophylactic low molecular weight heparin. And if fewer than 2 risk factors are there, then they are considered to be lower risk of DVT, and early mobilization and option of dehydration. So both prenatal and postnatal prophylactic dose of low molecular weight heparin is dependent on the dose. In 50 to 90, the prophylactic dose is 40 milligram OD for the enoxaparin. So the most important individual risk factor is personal history of thrombosis, and the second most important risk factor is the thrombophilia. Then there is personal history of venous thromboembolism that was associated with the non-recurrent risk factors, or if the first degree relative has the thrombophilia with high history of high risk thrombophilia, that is all the homozygous forms of the protein C deficiency, protein S deficiency, and all. So testing for inherited thrombophilia in women who have experienced recurrent pregnancy loss or placental abruption is not recommended. It should be done only when these 2 criteria are there. That is, there is personal history of BP, non-recurrent risk, or there is first degree relative with history of high-risk thrombophilia. So now coming to clinical sign and symptoms of deep vein thrombosis. Usually the lower extremity DVT can be symptomatic, it can be asymptomatic. Most commonly, more than 80% of the women, the lower extremity is affected, and the patient complains of pain, swelling, and the calf tenderness. A difference in calf circumference of more than 2 centimeters is suggestive of deep vein thrombosis in the lower extremity. Left leg, already saw, is the most common site of venous thrombosis, and here you can see that the right iliac artery is compressing on the left iliac vein, and this leads to the compression of the left common iliac vein, resulting in increased risk of venous thrombosis on the left side. So hormone signs may not be demonstrable in PVT, and it lacks the specificity, and pregnant women often experience symptoms like pain, tenderness, and swelling of the legs, which mimic the deep vein thrombosis. So what are the signs of massive DVT? The patient can either have phlegmasia albadolens, where there is edema, pain, and blanching without cyanosis, and the patient can progress to develop phlegmasia dolens, where the patient has pain, edema, and cyanosis, with progresses from the distal to the proximal areas, as you can see in the photographs. Now, the symptoms of pulmonary embolism are dyspnea, chest pain, cough, hemoptysis, and collapse, and the patient will have tachycardia, tachypnea, signs of DVT, fever, leukocytosis, and cyanosis. Now, coming to the investigations, the compression duplex ultrasound is the diagnostic modality of choice for deep vein thrombosis. These chest X-ray, ECG, ABG, CTPA, and VQ scanning can be done if the pulmonary embolism is suspected. So this compression duplex ultrasound, it can be done either through the gray scale, and it can be complemented with color Doppler to visualize the flow and the movement of the structure. The whole venous network is to be scanned, including the bilateral inferior vena cava, the iliac veins, the femoral vein, the popliteal vein, and the calf veins. And DVT is diagnosed when there is lack of compressibility of a deep vein, and for the iliac veins in the absence of Doppler flow or direct visualization of the thrombus. So the sensitivity of serial compression ultrasound with Doppler is 94.1%, and predictive value is 99.5%. So what are the drawbacks of this compression venous Doppler ultrasounds? The problem is that during pregnancy, the visualization of the veins may be difficult due to the leg edema or the gravid uterus, and isolated iliac vein thrombosis are very difficult to be diagnosed because of lack of compressibility of the veins. And also the pregnancy changes the anatomy and the physiology of the veins, and there is increase in vessel diameter and decrease in the flow velocity, difficulties for ultrasound that may persist for few days to weeks after delivery. Now, chest X-ray abnormal features when the patient has pulmonary embolism are atelectasis, effusion, focal opacity, or regional oligemia, which can be shown by the arrows as Westermann sign or the Alga sign. ECG will show certain changes the ABG will show hypoxemia, hypocapnia, and respiratory alkalosis. Now, both CTPA and ventilation perfusion scan can be done, but ventilation perfusion scan is considered to be the choice for young women if there is family history of breast cancer or if the patient has had a previous CT scan. So if there is any pregnant woman with suspected pulmonary embolism and has the signs and symptoms of deep vein thrombosis, bilateral compression ultrasound leg studies should be done, and diagnosis of DVT may indirectly confirm the diagnosis of preeclampsia since anticoagulant therapy is the same for both, and further investigation may not be necessary. So we should avoid doing CTPA or VQ scan if the patient has signs symptoms of deep vein thrombosis, in order to limit the radiation exposure. The D-dimer test, these are controversial and the values are itself raised during pregnancy, so they should not be relied upon. And we have tests. So the algorithm is that if you suspect DVT, get a compression duplex ultrasound. If the ultrasound confirms the diagnosis, start the anticoagulant treatment. But if the ultrasound is negative, and there is low level of clinical suspicion, the anticoagulant treatment can be discontinued. But even after a negative ultrasound, if there is high level of clinical suspicion, then anticoagulant treatment should be discontinued, but the ultrasound should be repeated on days 3 and 7. So we call it serial compression duplex ultrasound. So if it is negative, but there is high level of clinical suspicion, stop anticoagulant treatment, but repeat it again on day 3 and 7. And if it is positive, then restart anticoagulant. If it is negative, then no further treatment is required. So this is the diagnostic algorithm for suspected pulmonary embolism. So in patients with suspected DVT, if we go for a proximal compression ultrasound, if it is negative, but there is isolated iliac vein thrombosis, go for Doppler ultrasound or CT or MR imaging or venography. And if it is proven, then treat it. But if it is negative, then you can go for either the D-dimer testing or you can go for the CTPA or the VQ scan. And if positive, then repeat it on day 3 and 7. And if positive, then treat it. So now coming to the management portion, we have to do both the risk assessment and initiate the thromboprophylaxis using heparin. There are certain specific conditions like when there is massive life-threatening pulmonary embolism in pregnancy and puerperium, and what should be the anticoagulant therapy and titrations during labor, delivery, and the puerperium, and certain additional therapies when woman has previous VT. So we have the several anticoagulants available like heparin, danopranoid, and the warfarin and others, and we are going to discuss each of them in very short. So what baseline blood investigation should be performed before initiating anticoagulant therapy? We should have a complete hemogram, a coagulation screen, kidney function test, and a liver function test. Thrombophilia screening is not recommended prior to therapy because during pregnancy, the physiological changes can alter the thrombophilia screening. Doses of low molecular weight heparin are based on the weight, and for thromboprophylaxis, the weight which is to be taken is the most recent weight which is to be used for guiding the dose. So the dose is, if the patient is less than 50, the oxygen started in the dose of 20 milligram daily. If between 50 to 90, like most of our women, the dose is 40 milligram OD. Now, for therapeutic regime for low molecular weight heparin, when the patient is clinically suspected to have DVT, she already has DVT or pulmonary embolism, then the dose increases to BD dose. If it is less than 50, then the dose is 40 milligram. From 50 to 69, it is 60 milligram BD. Now, the unfractionated heparin is preferred over low molecular weight heparin in the peripartum phase, when there is risk of hemorrhage or when their regional anesthetic techniques may be required. For example, if no low molecular weight heparin has been given for the past 24 hours, but the woman has not yet delivered, then there is concern about delaying further doses of anticoagulation. So in those cases, we can give prophylactic dose of unfractionated heparin and repeat it every 12 hours until low molecular weight heparin can be resumed after delivery. So in the peripartum phase, better to switch over to unfractionated heparin because you have a control over it. You can stop it and you can reverse its effect if you require. So the comparison between low molecular weight and the unfractionated, we have low molecular weight heparin has higher bioavailability after the subcutaneous route, and the bioavailability of unfractionated heparin cannot be predicted because of variable binding to endothelium as well as the plasma proteins. And of course, the unfractionated heparin effects can be reverted back with protamine sulfate, but we don't have anything for the low molecular weight. Doses for unfractionated heparin will depend on the whether we are using it for prophylaxis or for the therapeutic use, and it is different according to the different trimesters. Now, should blood tests be performed to monitor heparin therapy in pregnancy? Yes, routine platelet count monitoring is not required in obstetric patients as risk of heparin-induced thrombocytopenia is very low. It is more in patients with surgical procedures, and it is also more likely with unfractionated heparin. Okay? And routine measurement of peak anti-TNF activity for patients on low molecular weight heparin is not recommended except for situations when the patient has extremes of body weight and other complicating factors like renal impairment or recurrent VT. The contraindications being if the patient has any bleeding disorder like hemophilia and the von Willebrand disorders, or the patient has thrombocytopenia, or she has severe renal and liver disease or uncontrolled hypertension. Now, coming to anticoagulant therapy during labor and delivery, for elective delivery, if the patient has been on low molecular weight heparin, it should be stopped 24 hours if the dose was therapeutic, and or 12 hours if the dose was prophylactic before induction of labor or cesarean section. If the patient was receiving subcutaneous unfractionated heparin, it should have been stopped 12 hours before, or if the patient was receiving IV unfractionated heparin, it should be stopped 6 hours before induction of labor or regional anesthesia. Now, prophylactic dose of low molecular weight heparin, it should be given 4 hours after in the post-operative phase, at least 4 hours after removal of the epidural catheter, or else there is risk of bleeding. It should not be given for at least 4 hours after epidural catheter has been removed, and the catheter should not be removed within 12 hours of most recent injection in order to minimize the risk of bleeding because of anticoagulation. So in patients who are receiving therapeutic dose of low molecular weight heparin, then abdominal drains, either the abdominal drain or the subcutaneous rectal sheath drain should be considered, and the skin incision should be closed with interrupted sutures in order to allow any drainage of any hematoma. Now, after delivery, in the postnatal phase, women should be offered a choice of low molecular weight heparin or oral anticoagulant therapy after discussion about the need for regular blood test for monitoring of warfarin, particularly during the first 10 days of the treatment. INR should be checked on day 2 of warfarin treatment, and subsequent doses should be titrated to maintain the INR between 2 to 3. So, heparin therapy is continued until the INR is more than 2 for at least 24 hours. Okay, so this is very important. In the postnatal phase, you start both the heparin as well as warfarin. You continue the heparin till the INR is more than 2 for at least 24 hours. And we avoid giving postpartum warfarin until at least 5th day or for longer in women at risk of postpartum infection. And you should advise the women that neither heparin nor warfarin is contraindicated in breastfeeding population. So now coming to management of the massive life-threatening pulmonary embolism in pregnancy and prepuberty, of course, it has to be done by a multidisciplinary team, and diagnosis should be made within 1 hour of presentation using an urgent portable echocardiograph or a CTPA. And if massive pulmonary embolism is confirmed, then immediate thrombolysis should be considered. IV unfractionated heparin is the preferred treatment for initial treatment in massive pulmonary embolism with cardiovascular compromise. Now, how do we define massive pulmonary embolism? It is when there is acute pulmonary embolism with sustained hypotension requiring inotropic support, or when the patient is pulseless or has profound bradycardia with sign and symptoms of shock. So in those patients, we give loading dose of unfractionated heparin by IV route 80 units per kg, and we continue the maintenance dose of 18 units per kg per hour. And it is mandatory to measure the APTT levels 4 to 6 hours after the loading dose and 6 hours after any dose change, and at least daily when in the therapeutic range. And the target is to attain APTT ratio to 1.5 to 2.5 average control value. And we have to adjust the dose of the unfractionated heparin according to the APTT levels. Now, if the patient ever develops heparin toxicity, then the antidote is protamine sulfate, and it is to rapidly reverse the effects of unfractionated heparin in patients with serious severe bleeding or risk of severe bleeding because of imminent vaginal or cesarean. And if the bleeding persists, then we can withhold the anticoagulation, and if possible, until the bleeding stops, and then again restart the anticoagulation. So patients who require venous thromboembolism prophylaxis but who cannot be given heparin because of this intolerance or toxicity, then those patients can be managed with mechanical means or inferior venous. So now, role of thrombolytic therapy, streptokinase, TPA, and urokinase, these should be given if the patient is having massive life-threatening pulmonary embolism with hemodynamic compromise. And it has been seen that if the patients are treated with fibrinolytic agent, they have faster restoration of lung perfusion as compared to those who are treated with only heparin. The contraindications of thrombolytic are any prior intracranial hemorrhage, history of stroke within 3 months, or any risk of bleeding. So the danaprenoid, these are the heparinoids which are used in patients who are intolerant to heparin, either because of heparin-induced thrombocytopenia or because of skin allergy to heparins. Or fondaparinux, this is a pentasaccharide, and this would be a reasonable alternative when there is a need for anticoagulant prophylaxis or treatment in pregnancy, and heparin cannot be used because of either heparin-induced thrombocytopenia or other intolerance. Now, warfarin, it is the best anticoagulant. It can be safely used following delivery and in breastfeeding mothers. However, it needs close monitoring as it has the increased risk of postpartum hemorrhage and perineal hematoma as compared to low molecular weight heparin. So, but it is associated with congenital malformations like warfarin embryopathy, where is hypoplasia of the nasal bridge, congenital heart defects, agenesis of corpus callosum, and the stipple epiphysis. But of course, these congenital malformations are dose dependent, and the risk is increased only if the dose is more than 5 milligram. This is the photo of the warfarin embryopathy with hypoplasia of the nasal bone, and this is the typical facies of the warfarin embryopathy. So the complications, other complications because of warfarin, it can be increased risk of spontaneous miscarriage, stillbirth, neurological problems in baby, and of course, increased risk of fetal and the maternal hemorrhage. So in women who have previous recurrent venous thromboembolism and are on long-term warfarin, we should change them to low molecular weight heparin as soon as the pregnancy is confirmed, ideally within 2 weeks of the missed period and before 6 weeks of pregnancy. So those patients who have been receiving long-term warfarin therapy, as soon as they become pregnant, switch over to heparin therapy. And women getting long-term anticoagulation with warfarin, the conversion from low molecular weight heparin back to warfarin should be delayed for at least 5 to 7 days after delivery in order to minimize the risk of hemorrhage during this period of overlap. The warfarin-associated bleeding can be controlled by discontinuing warfarin, administering vitamin K, using prothrombin complex citrate, and the monitoring should be done with PT-INR at approximately 30 minutes after prothrombin complex administration. Low-dose aspirin is not recommended for thromboprophylaxis in obstetric patients, and dextran should be avoided both antenatally and intrapartum because of risk of the anaphylactoid reaction. There are certain additional therapies like IVC filters, which are to be given in peripartum period if the patient has iliac vein VTE and or with proven DVT and who have contraindications or complications of failure of anticoagulation therapy and the patient have free floating thrombi following massive pulmonary embolism. Now, elastic compression stockings of appropriate size with graduated compression with calf pressure of 14 to 15 millimeters of mercury is recommended during pregnancy and puerperium for women who are hospitalized post cesarean section or are at risk of VTE because of previous VTE or more than 4 risk factors antenatally or more than 2 risk factors postnatally, or if they are traveling long distance for more than 4 hours. So, how should women with previous venous thromboembolism be stratified to determine management in pregnancy? So, if the woman has venous thromboembolism that is associated with antithrombin 3 deficiency or APS or recurrent VTE, then they will be already on long-term oral anticoagulation. So, in these patients, we have to initiate thromboprophylaxis with low-dose, low molecular weight heparin and continue it till 6 weeks postpartum and then return to oral anticoagulant therapy after delivery. So this antithrombin 3 deficiency is one of the high risk thrombophilia and that is why they need prophylaxis for from early in pregnancy till 6 weeks postpartum. Those who have venous thromboembolism that was unprovoked or idiopathic or related to estrogen containing contraception or pregnancy or because of transient risk factors, then in those cases, the thromboprophylaxis should be continued throughout the antenatal period and 6 weeks postpartum. And those where the VTE was provoked by major surgery, from which the patient has recovered and has no other risk factors, then we can initiate thromboprophylaxis from 28 weeks of gestation. So, contraception in a patient with deep vein pulmonary thrombosis. So if the patient has history of DVT or pulmonary embolism, there is a big no for combined oral contraception and the safest is the copper T IUDs. And if the patient has acute DVT or pulmonary embolism, then also if the patient requires contraception, we should always go by the safer ones like the copper T IUDs. Now, some words about the anticoagulants in mechanical heart valves. It is indicated only when the patient is having mechanical valves and not when the patient is on bioprosthetic valves. Here we do the switch over from warfarin to heparin starting from 6 weeks and continue the heparin. It can be either unfractionated or low molecular weight heparin from 12 to 36 weeks of gestation. Warfarin is restarted, and after 36 weeks, we have to stop warfarin and restart heparin till the labor. And we start after 6 hours of normal delivery and 24 hours of cesarean section. We omit heparin only after overlapping with warfarin once the target INR is achieved. So these are the 2014 American Heart Association Valvular Heart Disease Guidelines in women with mechanical heart valve. And they have recommended that if the patient was on baseline warfarin less than 5 milligram and the patient has presented to you in the first trimester, then we can continue with the warfarin in the first trimester also, if the initial dose was less than 5 milligram with the INR monitoring to be maintained between 2.5 to 3.5. But if the woman is not at all ready to take risk of warfarin emboropathy, then we can give her dose adjusted low molecular weight heparin and or we can give her unfractionated heparin, maintaining the APTT at least 2 times the control. In the second and third trimester, warfarin and aspirin can be given, and before planned delivery, we discontinue the warfarin and start the dose-adjusted infusion of unfractionated heparin with APTT at least 2 times the control. Now, we cannot complete this presentation on DVT without having a word about COVID-19, which has created so much havoc in our lives. So, what about thromboembolism in COVID-19 patients? Where normally indicated, thromboprophylaxis should still be offered and administered as prescribed during the COVID-19 pandemic. And for pregnant women who are hospitalized, all pregnant women who are hospitalized or have confirmed COVID-19 should be offered thromboprophylaxis for 10 days following hospital discharge. And if they have excessive symptoms or persistent morbidity, then we can continue heparin for longer than 10 days. Okay. And so the take home message is that the risk is highest in the postpartum period for venous thromboembolism. The single most important risk factor is previous history of venous thromboembolism. Compression ultrasound sonography is the primary diagnostic test in DVT. In case of high level of clinical suspicion, therapy can be started before the objective diagnosis is made unless there is a contraindication. Performing thrombophilia screening prior to therapy is not recommended. Low molecular weight heparin is preferred over unfractionated heparin except for in peripartum period, and postpartum warfarin is to be avoided until at least 5 days and or longer if the woman is at increased risk of postpartum hemorrhage. Thank you so much.
Thank you, Archana. It was really extensive talk. I invite Aruna Nigam Madam to conclude the session of Dr. Archana. Dr. Aruna Nigam is there.
Yeah, I am very much there,
Yeah.
but they have unmuted me. So it was a very, that's what I was trying to just make it with my hands and mouth. So it was a very, it was an excellent presentation by Dr. Archana, and she has left no stone unturned to cover each and everything. Just, I would like to summarize it in a way that deep vein thrombosis is an entity which can be encountered with from any of us. So we should not be missing it. Remember that it is not the deep veins of the leg which are important. It is the deep vein of the pelvis which are more commonly encountered, and has been very clearly, nicely shown by Dr. Archana in a figure that a May-Turner syndrome can occur because of the compression of the left common iliac vein by a right common iliac artery. A second very important thing, we should be learning that you have to do a clinical examination thoroughly by examining a pulse, a chest, blood pressure, and the limbs, which is a very important thing, especially in a postpartum cases, if any of the postgraduates are attending this case. If you have a doubt of tachycardia, breathlessness, some amount of tenderness in the legs, so don't wait for Homan sign. If it is a clinical suspicion, you are diagnosing it, suspecting it in the evening. Or remember, all emergencies come in the evening or the night. None of them come in the night when your senior consultant is there. So give your suspicion to your consultant or a senior or yourself. You can easily administer 5,000 of heparin. Remember that one vial is 25,000 international units. So immediately give 5,000 of international unit. Start 1,000 international unit in a saline. Put in whole 25,000 in one drip. Start with 1,000 international unit hourly till you get an ultrasonologist, because each and every person is not having a AIMS-like setup or a very good setup. So do it for next 6 to 8 hours so that you are not losing that golden hours. You are not going to do any harm to patient. It is going to save the life of that woman, and it can decrease the morbidity and mortality. And whenever your ultrasonologist come, you can make a diagnosis and then continue with the therapy or discontinue with the therapy. That is the most important point whenever you are dealing or suspecting the deep vein thrombosis. This is very common. Another important thing which I like to add, that compression DVT pump can be used in a high-risk cases with a pressure of 35 to 40 millimeter of mercury. And these DVT pump, remember that you have to check on your own, not rely on your sister, not rely on your junior, because they are so loosely tied when they are tied by your nursing staff that there is no effect. So these are the practical aspects which you have to learn and which you have to implicate in your practice, and you can save the hundreds of lives by doing just few of the things and then following the protocol beautifully elaborated by Dr. Archana. Thank you all, and thank you organizers for such nice topics being covered. Thank you.
Thank you so much, Dr. Aruna ma'am, for such nice words.
Really, Dr. Archana, it was so extensive, and we have revised all the things in your presentation. Was really too good, and learned a lot. Fonda, Perinox, and everything you have covered so well.
Very nice.
Yeah.
Thank you
so it was pleasure, Aruna Madam. You were here with us and you shared the pearls of wisdom with us. With that, we would like to finish this our academic session, and I would extend My thanks to Foxy Dr. Shanta Kumari Madam, Madhuri Patel Madam, and Vipin Sir, and also Komal Chavan Madam, who is always so encouraging and she's always believing in good level academics. So thank you, Komal Madam. And I would like to thank all our esteemed speakers, Achla Madam, Dr. Leela Vyas Ma'am, and Dr. Kavita Bhatti Ma'am, Dr. Vidhu Mudgal, Dr. Archana, and Dr. Aruna Nigam Madam, Dr. Reeti Mehra, Aditi Tandon, Mala Srivastav Madam, Krishna Madam, who took out their important time from their busy schedule and made this academic meet a great success. I would like to thank Shikha Singh Madam, and I invite Shikha Singh Ma'am if you have some concluding remarks for the academic meet, Madam. So with that, we can, and Gurpreet and Geeta, our MOCs were really wonderful. So I would like to thank all the dignitaries and the attendees who have taken out time and helped this CME.
Congratulations and best wishes to all of you. Very nicely arranged. Once again, congratulations.
Thank you.
Thank you.
Thank you.
So we can leave.